Smile. Recordings keep coming. So recording is still syncing the machine.
We have the recording now, Dr. G. You got it back.
Yeah, we have the recording now. Excellent. Welcome to Pharmacology 2. So today we have a very important topic is about diabetes mellitus. So I want your attention. I want all your questions. Participation is vital for our dynamic of our course. So please, you're very welcome. So all questions are very, very, very welcome. Okay. All right. So we can start in different ways when we talk about diabetes mellitus. We can start with case scenarios. We can start with some history. We can start with asking what is if you know some patients with diabetes mellitus, and we are going to do a combination about that. I'll tell you, I've been preparing. There is so much material, so please, I want you to pay attention, very, very careful. You know why? Because diabetes mellitus is one of the is very important. It's a very much prevalent disease in the United States. And we will see some numbers to see how important is that and how you can recognize a patient who has risk for diabetes mellitus. Okay, so let's get started and let's go to our first slide. All right, pharmacology and diabetes mellitus. All right, see, if you see here, we have what happened with animation. Animation is gone. So let's see this one. No, animation is gone. Oh, okay. All right, whatever. All right, so we have, this is a waterfall, and just I'm trying to visualize here, what does it mean, the word diabetes mellitus, okay? So please, diabetes mellitus. Diabetes means coming, if you can read there, Greek means siphon, to pass through. So it's basically running water, right? So that is what means diabetes in Greek. So running water. And mellitus means sweet. Mellitus was sweet. In the past, in the 1800s, there was no laboratory test and all that, and people was those doctors was trying to taste the urine, taste with the tongue, yes, to see if there is some sweet there, but was really not a very valuable test. But why? Because when somebody have hypoglycemia, or there is no already any sugar in blood, so the urine is not going to contain any sugar anymore. At the beginning, yes, because you have high levels of glucose, but there is a moment that the glucose is gone. So actually, that is an intent. They was trying to make a diagnosis. All right. So diabetes mellitus, does it mean? So sweet urine. Okay. So that is from the Greek. All right. So here we have some historical reference here. This is a papyrus that actually they was having in 1552 BC. They was actually seeing the description of this disease. So they was considered, they was actually describing the polyuria. What is polyuria? What causes polyuria in diabetes mellitus? We are going to see that today. In the first century, diabetes mellitus was described by this Aratius, and there was, in that first century, there was considered that they was urinating so much that they was thinking that all the internal organs was melting. So they didn't know the anatomy and the physiology that we know now. And they was thinking that all the internal organs was melting and going away. And actually the evidence that the patient basically was losing weight, especially in diabetes type 1. Then actually about the same time, we have, there was described by Galen. Galen is the father of anatomy and physiology, is the father of anatomy and physiology. There was actually trying or thinking that the problem was the kidneys. The kidneys was thinking that was the problem of diabetes mellitus. So they didn't know that was really a metabolic disorder. And we are going to see, and like 20 years ago, 25 years ago, they just discovered that diabetes mellitus type 1 was actually an autoimmune disorder, and we will talk more about that. All right, so let's keep moving. All right, so the prevalence. Prevalence is the new cases and the old cases. In 2018, actually about 30 million people. So that means that we have 10 to 11% of the population of United States are having this problem of diabetes mellitus. All right, so we have about 7 million people do not know how much they have actually, they're pre-diabetic. All right, so here we have 84 million people are pre-diabetic, Same million doesn't know that they have it, but 84 million are having actually pre-diabetes. So that means that we have total population in the United States 330 million people. So 10%, 11%. So that means from 10 people in the United States, one is actually diabetic. It's a lot, okay? It's a lot. And 84 million are basically 1/3. If you multiply 80 by 3, it's 240. It's actually, let's make it like a 40%. 40% of the population of the United States are pre-diabetic. 40%. 40%. So that means that from every 10 people, 4 are pre-diabetic. And that is a consequence of the changes of your diet habits. For example, you already know that if you have you take glucose for 10 years, not consecutive years, but accumulate. So you can have 1 year a lot of sugar, the other year you try to control yourself, and the next year you start to increase your sugar again. But in your span life, you accumulate 10 years of having high ingestion of glucose. That is going to increase your risk for diabetes mellitus. Okay. All right. So that is the importance about the diabetes mellitus. All right. So we have 2 cases that we are going to talk today. We have a previous. Listen, I want you to know the purpose of this cases study is to let you know how much you know about diabetes mellitus, how much you don't know, and how much you want to know in order to help this person. Okay, so let's get started. A previously healthy 12-year-old complains of fatigue and excess thirsty polydipsia. His mother mentioned that he used the bathroom quite frequently, polyuria, and friends at the school tease him about this behavior. His mother is also concerned because he has lost 10 pounds despite eating everything inside. A no-fasting blood glucose test, a plasma glucose of 220 milligrams per deciliter, and the serum insulin levels substantially reduced. Okay, so do you understand what I'm saying? Do you basically can follow what is going on here? All right. So
Yes.
excellent. To confirm the diagnosis, an oral glucose tolerance test, or GTT, is performed and shows a plasma glucose levels of 225 milligrams after 2 hours of administration of 75 grams of glucose. So if you see here, this patient is symptomatic. You're already familiar with the word symptomatic, right? What do you mean symptomatic?
You're presenting signs and symptoms.
Signs and symptoms, right? And when I said asymptomatic, means that is not actually having signs and symptoms, okay? And when I said I'm going to give a symptomatic medication, that means that it's a drug that is going to come signs and symptoms, right? Okay, perfect. All right, so we have this case, and what is relevant for this case? First of all, the age. Second, they have signs and symptoms, right? Third are going to be some laboratory tests. some laboratory tests that are confirming what we suspect. All right, so this case, what do you think it is?
Diabetes?
Diabetes, yeah, that is the topic, right? What type of diabetes?
Type 1.
Is the type 1. Type 1. Why is happening the type 1 diabetes? We will see that in a few moments. Second case. A middle-aged obese. So another case is you go to the ER and there is coming a patient who is a middle-aged obese man evaluated for a pre-employment physical exam. Okay. Complaints of recent polyuria and polydipsia. His not fasting plasma glucose is 275 milligrams per deciliter. You know, 1 deciliter is 100 mLs, right? So that means that you have 275 milligrams of glucose for every 100 mLs of blood. That is DL, deciliters. All right. Both of his parents were overweight. So what is telling you here? Genetic factor. Has sugar problems and die for cardiovascular complications because of that. You take the time to educate him about diabetes and plan a follow-up to a visit for 2 weeks. Fasting lab tests show a plasma glucose of 180, total cholesterol 250 milligrams. What is the normal value of cholesterol? What is the normal value of cholesterol? That is important. That is important.
200?
200, yes. Less than 200. What are the values of triglycerides? Normal. Write down that and nail it in your mind because part of the treatment is of cardio. So we already passed cardiovascular, right? In cardiovascular, you know that we need to treat with antilipemics, right? And for that, you need to know the values of HDL, LDL, cholesterol, triglycerides. Levels of triglycerides less than 150. Levels of cholesterol less than 200. Levels of HDL more than 60. And LDL less than 100. Okay? All right, so urea analysis show microalbuminuria. What is microalbuminuria? Urea analysis. Urea analysis means exam of the urine, right? And you know the urine shouldn't be showing any proteins at all. Why? Because the proteins are too big to pass through the glomerulus, all right? So the pores, the openings of the glomerulus. What is the glomerulus? It's a capillary. What is a glomerulus? It's a capillary. And the capillary, they have openings that are small enough that are small, they're going to allow only molecules passing on the same size. And proteins are too big. Red blood cells are too big. They cannot pass. But in this case, we found some levels of albumin in the urine. So that means that filtration of the glomerulus are being affected. So it's dilated, inflamed, and that can cause actually escape of some of these elements. So what is telling you here? The kidney are being affected. Okay, so probably we need to have other exams, all right, like Chem7 or the basic metabolic panel. All right, so pharmacotherapy is initiated with metformin. So what is the metformin? Metformin is an oral anti-diabetic medication. And the patient is educated about the importance of diet and exercise. So what is important exercise? Why is important about a diet? You need to remember this and write down this, that diabetes mellitus type 2, the 95% of the treatment, 95% of the treatment is diet and exercises. 95% of the success, I will say, of the treatment are going to be actually what? That diet and exercise. But why exercises? Why exercises? Why do we need, how exercises really impact on the health of the patient, or not only in this patient, but in everywhere. We will see that in a few moments. 6 months later, his hemoglobin A1C has decreased from 8.5 to 6.5. So that is going to be the laboratory test, the laboratory values that you're going to memorize today. Okay? So overall, what you see in this patient is that what kind of diabetes it is. Based on the clinical presentation. Diabetes type what? Type 3, type 4, type 5?
Type 2.
Type 2, right? Type 2. So can you imagine now? Imagine yourself. You are, for example, you are not young enough, like 12 years old. You are, let's put it, 25 years old, 22, 23, 21, 25 years old. And they check your glucose in blood, and you are not that obese, you are not that thin, and you have this elevation of glucose in your blood. So now what is actually the problem? To know if this is diabetes type 1 or diabetes type 2, we don't know. In diabetes type 1, we need to use insulin. In diabetes type 2, we are going to just decrease the levels of glucose. Everything that is look like a very kind of gray, we are going to clarify in this class. All right. So any questions so far, please? The purpose of this, I hope I accomplish my goal, is to make you focus and actually have the interest to concentrate and focus in this class. Okay? All right, so let's start with the definition of diabetes mellitus. Diabetes mellitus is a group of diseases characterized by hyperglycemia. What are the normal values of glucose? We are going to see all of these today. And abnormalities in fat, carbohydrates, proteins, and metabolism. Yes, so in diabetes mellitus, what is going to be affecting primary are going to be the carbohydrates. The carbohydrates are not be able to be used by the body. So what is going to take hand the diabetes mellitus? Are going to take hand from the fat. So carbohydrates and fat are going to be actually part of the problem. And proteins, yes, because the one of the main problems, or the main problem for elevation of glucose in blood in diabetes mellitus is the gluconeogenesis. Gluconeogenesis is the major component of actually increase of glucose in blood, the gluconeogenesis. And what is gluconeogenesis? Is the transformation of glucose from proteins. So you already know that diabetes mellitus are going to be affect the three macronutrients, the fat, carbohydrates, and the proteins. First of all, it's going to be affect all the carbohydrates metabolism. It's the main thing. Then fat are going to be compromised when you have complications. Complications can produce DKA or hyperglycemia syndrome. And then you have the proteins. The proteins is a waste of your proteins in your muscles. Why? Because the body cannot use fat because it's depleted, or the carbohydrates are gone. All right, so we already talked about the incidence here. So we have, let me see here, we'll go here, some associations. This is already, we talked about that. So, oh, by the way, there's some questions for NCLEX here. Normal values of glucose is 70 to 99. 70 to 99, okay? 70 in fasting, 70 to 99 milligrams of glucose per deciliter, okay? All right, so we have this is a little, prevalence is going to be about 10%, so it's not 7, 8, that was like 5 years ago. So now it's about 10%, just remember that 10% prevalence, okay? High incidence of diabetes mellitus type 2. Listen, female, F, fat, F, 45, F, family predisposition, F, and find diagnosis after complication appears. So that is one of the highest risks for diabetes mellitus type 2. Okay? Female, fat, 45, family predisposition, and basically these patients go to the hospital when they are already have complications. Higher incidence, higher incidence. This is another question for your med search and for your pharmacology. African American population, Latin American or Hispanic, American Indian, and female. Okay, African American, Hispanic, American Indian, and female are going to be higher incidence of diabetes type 2. Okay, so now most of the people, do you know somebody with diabetes mellitus?
Yes.
And that
Yes.
person is diabetes mellitus type 1 or type 2?
Type 2. Both.
Both?
Well, it's two different people, sorry. But yeah, it's type 1 and type 2 for each one of them, for one of
Okay.
each.
But you're not too far from the truth, huh? Because people who diabetes mellitus type 2 in latest stages, they can they need to start using insulin instead of just oral. Okay? All right, so very good. So you see here that, tell me, those patients having hypertension or no?
Yes.
Right? Somebody else have somebody with diabetes mellitus to know around? No? Hello?
Yes.
And that person is having hypertension or no?
Yes.
Right? So it's kind of situation, right? So why is hypertension is going to happen? You will know that today. Okay? So hypertension. So basically, the patient with diabetes mellitus, they increase the risk for hypertension because of the pathophysiology that I'm going to explain in a few moments. And increase, as you read here, let's read, heart disease and stroke is 2 to 4 times greater than those without diabetes mellitus. So you duplicate or quadruplicate your risk for have a CAD, so coronary arterial disease, or cerebral vascular accident, CBA, sorry, and increase very high. Okay with that? Now, all right, so let's keep going. All right, so associations. So these associations means that these patients are having high risk to develop diabetes mellitus. We have Hashimoto disease. Type 1 Hashimoto disease. Hashimoto disease. What is Hashimoto disease? Everybody? What is
Hypothyroidism.
what is the cause of that?
Low.
Autoimmune disorder, right? It's an autoimmune disorder. Yes or no?
Yes.
Yes or no?
Yes.
Yes. Okay. So please, participation, please. LES. Systemic lupus is systemic lupus erythematosus. SLE. Sorry, it's not less. I should put this. Right, so we have a systemic lupus erythematosus. What is lupus erythematosus? It's going to be an autoimmune disorder. So what is doing autoimmune disorder? When I say in autoimmune disorders, it's that something is destroyed, right? And autoimmune disorders, for some reason, we don't know when the body starts to produce antibodies against something that is your body. So your body doesn't recognize anymore your structures, your tissue. And what is going to do? Send antibodies to mark for destruction. That is what is happening. And in lupus, the organ, all systems are going to be affected, but the target, the main target for SLE is going to be the kidney. Celiac disease. Okay, celiac disease. This is actually, remember, you need to differentiate with lactose intolerance. with celiac disease. Celiac disease are going to participate in immune disorder. It's actually the gluten. You have allergies to gluten, so they're going to destroy your intestine. So if you see, do you know somebody with Hashimoto? Do you know somebody with lupus? Do you know somebody with celiac disease? Yes. So those are having higher risk for diabetes mellitus type 1. Another one is we have the type 2, the metabolic syndrome. The metabolic syndrome. The metabolic syndrome, how to recognize somebody with metabolic syndrome. In the past, this was called the syndrome X. But now, well, it's already a long time, it's called the metabolic syndrome. Metabolic syndrome is those patients who are taking a lot of salt. A cumulative 10 years, they can lead into hypertension, sodium hypertension. Same with the sugar. The sugar accumulated high levels of glucose in blood for 10 years, they are going to lead into diabetes mellitus, And you know, diabetes mellitus, this actually and hypertension are going to work together. They can actually, individual or together, they're going to lead into heart diseases, right? Like hypertension, atherosclerosis, strokes, right? So strokes. So those are the main things. Metabolic syndrome. How to recognize a person on the street with metabolic syndrome. Metabolic syndrome, you have the head, the neck, upper extremities, and lower extremities, normal size, proportional to your body. Thorax as well. But the abdomen, it looks like a pear. So it's going to see like a pear-shaped abdomen body of the patient. So you have big belly and actually normal arms and lower extremities. So that is how you recognize the what? The metabolic syndrome. That means that these people are eating a lot of Kentucky Fried Chicken, a lot of McDonald's, a lot of fast food, and without any repair. So actually metabolic syndrome. With the time, they're going to start developing hypertension. They start to develop diabetes mellitus, and the complications that imply that. The waist. What means the waist? So the waist. If you go to your homework, you have a ruler or a tape measuring, you're going to check your waist at the level of your upper portion of the hip. And the waist should be less than 30 in female and less than 35 in male. All right. And actually, if you have more than 30, that probably you need to check how is the wellness of the patient, how is the lifestyle, and lack of exercises, a lot of pizzas, a lot of Kentucky Fried Chicken, and that is telling you that probably this patient is in metabolic syndrome. That is one of the parameters. So 30 inches of your waist or more, less than 35 inches of the waist in male, 30 in female. You okay with that?
Yes.
Okay. So talking about the laboratory test, you're going to have, we have a fasting. You already know that the normal values of glucose is going to be 70 to 99, right? Milligrams per deciliter in fasting stage, fasting. Okay? In no fasting, when it's no fasting, it's going to be less than 126. Okay? No fasting. But when it's fasting, it's 70 to 99. Okay. So fasting, you have the diagnosis of diabetes mellitus when your laboratory test is showing you more than 126. So fasting more than 126. That is a diagnosis of diabetes mellitus. They are going to confirm with another test, right? So after 2 hours of ingestion of 75, so correct that please, 75 grams of glucose, 75 grams of glucose after 2 hours. So your values should be less than 200, but when it's equal or more than 200, that is going to be a diagnosis of diabetes mellitus. If you see in this picture, in this one, here we have a case number 1, 12 years old. We have enough fasting glucose, where is that? The GGT. So glucose tolerance. So that is when you give 75 grams of sugar and read after 2 hours the blood levels of sugar, and you see that should be less than 200. But in this case, it's 225. So it's very high. So that is the diagnosis of diabetes mellitus. So we don't know yet if this is diabetes type 1 or type 2. Why I'm saying that? Some of you are thinking, yeah, but I know diabetes mellitus type 1 occurs in young people. I know that diabetes mellitus type 2 occur in adult people. Yes and no. So that was like 30 years ago. 30 years ago, or even more, that we was calling diabetes type 1, the juvenile diabetes mellitus type 1, we was calling the juvenile diabetes. And the type 2, we was calling the adult diabetes. But nowadays, it's not actually that true, because people who are adult, they can start having diabetes mellitus type 1. And actually, diabetes type 1 can start in early ages too, nowadays. So this is not really valid anymore. People are still calling that, but definitely there's some overlap. So what is the cutoff that we call about this? About 30 years old. 30 years old. Below 30 years old is considered young. Above 30 years old is considered adult. Adult for diabetes mellitus. Okay? All right, so fasting, that is number 1. Fasting diagnosis for laboratory. So 100 in fasting, if you have 126 or more, diagnosis of diabetes mellitus. Fasting, glucose, after ingestion of glucose, 75 grams, if you read after 2 hours, you're going to have 200 milligrams or more diabetes mellitus. Anytime the hemoglobin, the A1C is going to be more than 6.5, that is actually the diagnosis of diabetes mellitus. Random, if you take an anytime random, so the glucose test you take in the school, and you find somebody with 200 milligrams per deciliter, that could be actually diabetes mellitus. And one more thing here. Laboratory tests, these are going to be diagnosis when all of these are accompanied by signs and symptoms. Signs and symptoms. What could be the signs and symptoms of diabetes mellitus? Number 1, polyuria. Number 2, polydipsy. Number 3, polyphagia. So you eat a lot, you drink a lot, eat and drink a lot, drink and eat a lot, and pee a lot. Okay? All right. So let's get from some laboratory tests here. Here's the values that you need to remember for your NCLEX. Okay? All right, so the pre-diabetic patient, we have the hemoglobin, A1C are going to be measure of the glucose that are interacting with the red blood cells. And that is giving you the story about 3 months in the past with this test. So what happened, how you control your glucose, and how was your glucose in the last 3 months. That's a very good test. All right, so here we have pre-diabetic are going to be 5.7 to 6.4. Okay, and you have diabetic patient with this test 6.5. Okay, so how to remember that? I just think about something. So the A1C, repeat A1C one time, everybody. A1C.
A1C.
Excellent. A1C. So what is the age of retirement? 65.
65.
Yeah, all right. So let's remember that. I know I just made it up right now. 6.5, just to remember. At retirement, you have diabetes. Just to remember, huh? It's not that every retired is going to have diabetes, right? Just to remember, okay? 6.5. So below that, we have 6.4 and down to 5.7, 5.7, 5%. So you see here 4, 5, 6, 7. So these numbers are very close. So 5.7 to 6.4 are going to be a patient with pre-diabetic. Pre-diabetic. We okay with that? Correct? Okay. Diabetes mellitus with signs and symptoms. Remember, all these did companion with signs and symptoms. Okay. We have random, so anytime the glucose are going to be more than 200. That is a diagnosis of diabetes mellitus. Fasting, plasma glucose levels. Fasting. When you're fasting, of course, you have less glucose in your blood because you were fasting, but the value should be lower in this case. So more than 126 on fasting patient that are going to tell you that patient is very likely to have diabetes mellitus. Diabetes mellitus. And we have the OGTT, is the oral glucose tolerance. Oral glucose tolerance test. Oral glucose tolerance test. The OGTT. You say OGTT. So people need to understand
OGTT.
it. Yeah, excellent. And if somebody say, what is OGTT? Well, that is the test, so you can explain. All right, so here we have that is going to be a less, should be equal or more than 200. So we have 200, the random and the OGTT, random. So more than 200. When it's fasting, suppose that you are not eating anything, right? So your glucose should be a little lower, and the lab tests are going to consider 126 in this case or more are going to be cause of diabetes mellitus. Okay? And the A1C retirement 6.5, 6.5, 6 equal 6.5 equal. If you touch 6.5, that is positive diagnosis. Okay? I mean, tell you that you probably have diabetes. You okay with that?
Yes.
Okay. This is an extra. I'm not going to ask that, but I want just to amplify your panoramic view about diabetes mellitus. In the past, there was actually a lot of difficulties to differentiate between diabetes mellitus type 1 or type 2. So I have high glucose, but I don't know if I'm type 1 or type 2, right? So, and there nowadays, they have about 5 years, they have around already some tests, and that are going to be antibodies. For that, I need to take advantage of this moment to explain you how happened diabetes mellitus type 1. Okay, listen to this. Erika, you like sugars, huh? Okay. All right. Okay. So, Jacob, Adriana, please, your cameras, please. All right. All right, Jacob. Okay, why are you turning off your cameras? Okay. All right. So, what I was saying, Adriana, please. Okay. All right. All right. So, number one, pancreas, mixed gland, exocrine gland, pancreatic juice. The other portion is the endocrine portion of the pancreas. That's why it's a mixed gland. The endocrine portion of the pancreas are going to have what we call the islet of Langerhans. Islet of Langerhans. We have the alpha cells who produce the glucagon, and we have the beta cells who produce the insulin. The majority of the cells of the islet of Langerhans, 75% of these cells in the islet of Langerhans are going to be beta cells. And another is going to be the delta cells. That is the somatostatin. That is the regulator of hormones. It's like the peacemaker. Or you don't want too much, you don't want too little. So somatostatin is doing that. Okay, so what happened here is that in early age, you start to have antibodies against the cells who produce the insulin. So you have antibodies. So your body, we don't know why or when it's happening, but the cells are going to be destroyed. How many of these islets of Langerhans we have in the pancreas? We have in the pancreas about 1 million of these islets of Langerhans. 1 million of islets of Langerhans. So you start to produce antibodies in early age. So you start to destroy the islets of Langerhans. But at the beginning, it's not evident because you are destroying these progressively, not at once. So little by little are going to start showing more and more signs and symptoms. And when is that happening? An average of 13 years old, diabetes mellitus type 1. Right? At 13 years old, you have about 60% of the islets of Langerhans destroyed. And that is the moment when you start to have less insulin because it's going to affect the islets of Langerhans. You okay with that?
Yes.
Yes.
Okay. All right. So that is considered up to sometimes they happen at 13 years old, at 15 years old, 20 years old, 30 years old. That is basically what we use as a cut-off. Less than 30 years old, you have diabetes mellitus type 1. Because why is taking that time? Because the destruction can be very fast or very slow or intermediate. But when you touch down 60% destruction, yes, Erika, of the islets of Langerhans, that is going to start giving signs and symptoms of diabetes type 1. Yes, Erika, go ahead.
Dr. G, did you say 30, 30 or 13?
30. 30.
When the
30.
when 60% of islets are destroyed, right?
Yes, that's correct. And that is a genetic factor. You know, there is family who is running with diabetes mellitus, right? And we already talked which population is going to be women, African American, Latin people, American Indian. So those are basically the population that are mostly affected. African American, very high, by the way. We okay? All right.
Yes.
So that is diabetes type 1. In diabetes, we are not talking about complications yet. So in diabetes type 1, what is happening is, remember this name, hypoinsulinemia. Hypoinsulinemia. Insulinemia. Hypoinsulinemia. So you have low levels of insulin in your blood. All right? Easy, Erika, easy. Okay. So you're taking too much sugar. You like what is that? What is that? Tell me. What is that candy? Okay. No,
Pandesal
candy. Okay.
bread.
All right.
It's a pandesal, Dr. G.
Okay, dear. All right, so here's diabetes mellitus type 1. Okay, so we have low levels of insulin. So tell me, everyone, what could be the treatment for diabetes mellitus type 1?
Insulin, yeah.
It's going to be insulin. I want everybody to, Juliet, where are you? Rinsin, Charlize, Diana, Jacob, Gerel, where are you? Alejandra.
I'm right here.
Yeah, Anna, yes, Anna C. Where is Anna C? Anna C, there you are. Sydney Sana. Okay, so yeah, participate. All right. What I was saying? Okay. So it's treatment the insulin. So you're going to give what the patient doesn't have, the insulin, correct? Now, what is the action of the insulin? Listen to this, very careful. The insulin, what it's doing is going to activate the receptors for insulin, and that insulin is going to allow or is going to open the doors or gates to enter glucose into the cell. So you have a mailman is knocking the door to give you the package, a book or whatever you want, right? And that is that they ring the bell, that is the ringing the bell is going to be the receptor. The insulin is the mailman. You open the door because the ring is a consequence of the door ring bell, right? Ring bell, ring door, doorbell, bell door.
Doorbell, Dr. G.
Okay, thank you. Doorbell. Okay, the doorbell. And this, as a consequence of that, you open the door and you receive the letter or whatever it is, right? It's exactly the same what happened with the insulin. Okay, the insulin is going to do that. All right, and please remember this. I told you this in the past. When glucose get into the cell,
It brings potassium.
it's going to enter with a little bit of potassium. Excellent. Very good. Very good. We are going to use that very soon. Okay, perfect. Now, in diabetes mellitus type 2, what is the problem? The problem is that, do you have insulin in diabetes mellitus type 2? The answer is
Yes.
yes. We have insulin. We have insulin. Yes, we have insulin. And all what I'm going to tell you, because I want you to tell me what is the treatment for diabetes mellitus type 2. Okay, so all what I'm going to elaborate is in order to make you think what is the treatment for diabetes mellitus type 2. Okay, now, so you have insulin. So the insulin is present into your bloodstream. Talking about diabetes mellitus type 2, the insulin is present in the blood. So if there is insulin, why is not getting the glucose inside the cell? Why? Because we call this a resistance to the insulin. There is a resistance, or we have the resistance to the insulin. Who is resistant to the insulin? The receptors. The receptors. So you have the mailman here, and he's ringing the bell, or whatever it is, okay? The bell is ringing, and it's not ringing. So the doorbell is not ringing anymore. It's not working. It's not working. The ring bell, or doorbell, or whatever it's called, is actually not working at all. So if that is not working, you don't know somebody is knocking the door. So you will never open the door. You will never receive your what they're sending to you. You okay with that? So what is the problem? The problem is the sensitivity of the receptors. The receptors for insulin are losing the sensitivity. I will try to explain how is that happening. Look at this. In diabetes type 2, listen very careful. You are actually eating a lot of sugar, correct? You're eating a lot of sugar, correct? So this sugar at the beginning the insulin is going to work okay. Are going to knock the door, and the receptors, right? The receptors are working properly. And these receptors are going to open the door. But little by little, these receptors are not responding to the stimulation of the insulin. You want proof of that? I will give you some proof here. I want you to do exercises. I want you to do like 20 pounds. Okay, so let's make it 5 pounds. 5 pounds exercises. So you can do, 5 pounds is nothing. I can do it, right? 5 pounds. 1, 2, 3, 5 pounds, 10, 20, then I start to having 50, 60, 70, right? So I cannot do anymore, right? Why? Because my arm is totally exhausted. So the overstimulation of the receptors but are going to change the shape of the receptors, are going to change the receptor shape. And the receptor with the time, because this overstimulation of the insulin on the receptors, why? Because you was eating a lot of sugar, that receptors are changing shape. And that means the receptor will not respond anymore effectively to the insulin. You got it? Now, that means that you have high levels of glucose in your blood. In diabetes type 1, you have high levels of glucose in blood. In diabetes type 1, you have high glucose in blood. The answer is yes. Why? Because there is no insulin to bring the glucose inside the cell. So glucose starts to accumulate in blood, hyperglycemia. Now, turn the page. In diabetes type 2, in diabetes mellitus type 2, you have high levels of glucose in blood as well. Even though you have insulin, the glucose cannot get inside. So in both cases, diabetes type 1 and 2, you're going to have what? You're going to have high levels of glucose. That is called hyperglycemia. So now, the easy one. If you told me that in diabetes type 1, the treatment will be is to give what the patient needs, insulin. But what could be the mechanisms of action of the drugs who are actually acting in diabetes type 2? What you should do as a treatment for diabetes type 2, besides diet and besides exercise?
Oral hypoglycemic agents.
Yeah, that is the name. But what is doing those medications? What do you think are doing?
Does it help bind the insulin to the receptor?
Wow, that is going to be a good thing. It's not being explored that way. But that is not the answer. But this is a very good, huh? That is a very good thinking. Keep going. What is the main problem?
The receptors.
Okay. And as a consequence of that, what could be the consequence of that?
High amount of glucose in the blood.
Excellent. High levels of glucose in the blood. Now, what we want to do? We would like to do, because the receptors, we cannot change the receptors. The receptors are already changed. The problem will be the high levels of glucose. So what is the solution here? Or try to resolve the problem is to decrease the levels of glucose in blood. That is the thing in diabetes type 2. Decrease the glucose in blood. In diabetes type 1 is to increase the insulin. In diabetes type 2, Alejandro, where are you going? In diabetes type 2 is to decrease the glucose. Okay? Now the questions of $1 million. How you think you can decrease the glucose in your blood? Don't tell me diet. Don't tell me diet. See, I got it. Okay.
Use of energy.
Okay. So tell me, how you produce glucose in your body?
Glycolysis? No, no.
Gluconeogenesis?
The gluconeogenesis. What else?
Glycolysis, right?
Glycolysis is to produce ATPs. So we have the write it down, this, please. Write it down. We are going to we produce glucose with the GLU, gluconeogenesis. Number one. Number two, the GLY, glycogenolysis. The glycogenolysis. What is the glycogenolysis? The glycogenolysis is turning the glycogen into glucose. Yes or no? Right?
Yes.
Yes.
Okay. So there is how also put in your paper, put increased glucose. Number one, gluconeogenesis. Number two, glycogenolysis. Number three, what is number three? The stress. Why stress, Driana?
Table of
Oh, no. Why stress?
table of 10.
Okay. All right. Who stimulates the stress?
School.
Cortisol, right? And when you're stressed, tell me, in addition to the cortisol, what is going up? Your
Glucose.
adrenaline or no?
Yes.
Yes. When you're scared, afraid, you want to kick, to beat somebody, you actually, your adrenaline go up, correct? And when your adrenaline go up, you are activating the sympathetic nervous system. And the sympathetic nervous system are going to improve, are going to activate the glucogenolysis, because you need, for fight and flight, you need glucose. In addition, the cortisol is doing his job too. The cortisol, what is doing? They are going to increase the gluconeogenesis. But in conclusion, when you are stressed, you're releasing cortisol and you're releasing adrenaline. And both are going to increase the glucose in blood. Do you hear somebody with diabetes mellitus? Please, 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 don't get upset. Don't get upset, please, because your glucose is going up. Do you hear that? Right? And that is the reason. Okay? So we have one. We have we was talking about the gluconeogenesis, glucogenolysis. We're talking about the sympathetic nervous system, the stress. Number four. So number four will be the absorption of glucose in the intestine. Absorption of glucose in the intestine. Absorption of glucose in the intestine. So we are going to do what? Decrease the absorption of glucose in the intestine. And that is a way to treat diabetes mellitus type 2. And the fifth one is to stimulate the secretion of more insulin. Stimulate. You're not giving insulin by injection in this stage. You're going to increase the production. There is medications who are going to produce more insulin in the cell, stimulate the beta cells to produce more insulin. So what is the treatment for diabetes mellitus type 2? Number one, drugs that are going to cut the gluconeogenesis. Number two, drugs who are going to block or cut the glycogenolysis means the glycogen into glucose. Number three, medications who are going to stimulate the production of the beta cells for more insulin. Then actually medications who are going to block the absorption of glucose by the intestines. And that is based on control your stress, correct? So that is, but tell me, stress can cause you hyperglycemia, yes or no?
Yes.
Right, that is actually the thing, right? So, but the stress is when you're upset or something. But please, I want you to have more landscape right now. Open the door. What about if you are sick? What about if you have a trauma? What about if you have an accident? That is not stress. Oh, I'm happy I have an accident. You cannot say that, right? Oh, I hit my head. Oh, I'm so happy. No, you cannot say that, right? So when you have injury and you have some accident or infections or whatever illness happening around you, that is going to basically increase your levels of glucose in blood. Okay? Because the stress are going to activate the cortisol and activate the stress can increase your fight or flight. So I want you to realize that the patient is just not a pill. You got it?
Yes.
Okay, so that is the treatment for that. So now, going back to my slide here, in this, actually, nowadays they have actually some laboratory tests to differentiate type 1 and type 2. So what is the antibody for GAT? So GAT is the glutathione and decarboxylate enzyme that is located in the pancreas, okay, in the pancreas. So that it means that there is antibodies who are destroying the pancreas. If they are present, that means that most likely this patient is having diabetes type 1. We have other antibodies that are going to attack the islets of Langerhans. And basically, we have the C-peptide. The C-peptide is going to, we know the C-peptide are equivalent to the insulin levels. I didn't say that they're the same, they're different. But the C-peptide is a protein that is, when you secrete insulin, the C-peptide go up. So you secrete more insulin, the C-peptide go up. So basically the levels are following each other. So if you have low levels of C-peptide, means that you don't produce insulin at all. And if you have antibodies for the islets of Langerhans or the beta cells, that is the antibodies, anti-GAT, are going to tell you that there is a presence of autoimmune disorder. So just to mention, I'm not going to ask that, right? So in conclusion, here we have that the difference between type 1 and type 2 is to find out antibodies or not. There is a specific antibodies who destroy the islets of Langerhans. You take that lab test, if these antibodies are present, most likely is diabetes type 1. If there's absence, there is no actually, is diabetes type 2. You okay with that?
Yes.
Okay. All right, so we are going to talk about different things about complications of diabetes mellitus, because that is going to impact in your nursing considerations about medication. All right, so let's get started. Diabetes mellitus complications. We have macrovascular problems and microvascular problems and infections. Okay, so macrovascular. So remember that diabetes mellitus is an autoimmune disorder. So for that, I'm going to give you a graphic that is going to explain you the pathophysiology of diabetes mellitus. And they're going to give you explanation of everything. I don't know, I tend to go from one way or to the other way. Let's go explore the other way. First, let's go on this so you will understand that later. All right, so we have macrovascular atherosclerosis. What is atherosclerosis? Please, at this time, you shouldn't be making mistakes anymore in your life that different with arteriosclerosis, right? Arterio is the old aging process, hardening of the vessels because low collagen, because you are more catabolic. Yeah, that is nothing to do here. We are talking about atherosclerosis. Atherosclerosis is the deposit of cholesterol. We call plaques of cholesterol, or atheromas. Hardening. Atherosclerosis. So that is going to be happening in actually patients with diabetes mellitus. We are going to see that in a few moments. Microvascular capillaries are going to basically affect microvascular. Microvascular is the small vessels, including the capillaries. And the capillaries are going to be affecting the long-term complications of the patient. Eyes, for example, you become blind. You become blind. With diabetes mellitus, you start to lose your vision. Diabetes mellitus is very bad. You're going to be blind. And that is because affect the small vessels, the capillaries. So there is no blood supply to the retina. The kidneys, the number one cause of kidney transplant, transplant are going to be diabetes mellitus. So in California alone, we have, okay, so what I was saying? What I was saying? Oh my God.
Kidney
Like
transplant.
kidney transplant.
Kidney transplant, yes. Thank you. In California, we have how much? How much was it? Well, anyhow, so we have about 15,000 kidney transplants in California every year. 15,000. And the transplant surgery is going to be like 500,000. This is like to buy a house. That is actually how much cost is a kidney transplant. All right, and the kidneys transplant can last 10, 15 years. That is one of the best transplants. It can have other organs can last 3, 4, 5 years maximum, but kidney can last for many, many years. And 15,000 people having transplant, but the waiting list is 50,000. So 3 times more. 30% of those patients are in dialysis, and actually in 1 year they're dead, but still in the waiting list. So it's not really an easy issue. Okay, kidneys and kidney. What happened? The vessels are not going to give blood supply to the kidneys, to the nephrons, and the nephrons start to die. Neuropathies as well. The neuropathies are going to lose the sensitivity. Remember these NCLEX. One of the assessments is the patient is referred that is walking over cottons. When he's walking, the patient feels he's walking over cottons. So why they feel so good? You feel good, your feet? No, because you are losing sensitivity. That means you are losing sensitivity. Infections are going to be taking longer time to heal that infection. So a little bit gray. I'm going to make it clear now. Look at this. This is a vessel. This is pathophysiology in 30 seconds. No, 3 minutes. Pathophysiology. In 3 minutes. And you will understand everything. So here we have a vessel. And you can see here that we have 3 layers, right? The endothelium or tunica intima, right? The tunica media and the adventitia. All the vessels are having that, correct? Yes or no? But here, what you have is increase of glucose all the time. You're eating a lot of glucose. You like Coca-Cola, whatever you like to eat. Glucose, your bread, you're eating a lot of glucose. Okay, high levels of glucose. So what happened with the glucose? There is a reaction that occurs between the endothelium, the tunica intima, that is endothelial cells, right? You're ready now, right? Endothelial cells, right? We got that? Plus glucose. Plus the glucose. So this reaction of endothelial cells and glucose is called the glycosylation. Glycosylation. Right? Glycosylation is a reaction of the endothelium of the glucose. Is the reaction of the endothelium cells of the internal, the lining of the vessels with the glucose. Now, what happened with the time? This inflammation, what is going to produce is an hypertrophy of the tunica media. Okay? And what does it mean? Look at this. This is the wall of the is going to be, let's put it this way, 1 year, 5 years, 10 years, 30 years. And what happened? The tunica media start to get bigger and bigger. Bigger and bigger. Bigger and bigger. Bigger and bigger. We are talking about time, years, huh? Bigger and bigger. The tunica media start to get big. Tunica media start to get bigger and bigger. Bigger and bigger. Bigger and bigger. Can you see? Now, at the beginning, there's this space where it's running the blood. But with the time, the more reaction with the glucose, with the endothelium, produce more hypertrophy of the tunica media. And what happened? The lumen of the vessel start to decrease and decrease and decrease and decrease. So at the end, you will have, if you have here at the beginning this vessel with this lumen, now at the end you will have this vessel with this lumen. So that means less oxygen, less nutrients. So that's why the ones who are going to be very much affected are the small vessels. Who are those? Especially the capillaries. The capillaries of what? Very common. Eyes, the retina, the choroid membrane. The capillaries are going to get narrow, so there is less oxygen and nutrients to give blood, to give supply to the retina. Retina start to decay and produce blindness. We have the kidneys. The kidneys, the afferent and the efferent. Afferent is the vessels who are bringing blood to the glomerulus. And this afferent is going to be blood supply to the nephron as well for nutrients. And what happens? You start to have less oxygen because with the time, it could be, depend, 5 years, 10 years, 30 years, depend how much you take care of you. You start to have problems. If you are very bad taking control of your glucose, in 5 years, you start to be in this stage. So that is variable, depends on how the patient is taking care of himself. So the kidneys start to get destroyed, the nephrons, destroy 60% again of the nephrons, you start to have kidney failure. Treatment, kidney transplant. Another neuropathy. The nerves are alive. And because they are alive, they need oxygen and nutrients. And the terminal nerves that are on the tip of your toes, your fingers, distal portion of your body are the ones who are more susceptible. Why? Because distally, the more distal, the more small the vessels are. And these are the first areas who are being affected. So you start to lose those terminal nerves, Pacini, Krausner, Meissner, whatever you want to call these receptors, and you start to lose the sensitivity. And what happened? If you lose sensitivity, the hot is not hot anymore. You take a teapot and say, a teapot, what are you doing? No, nothing. So they don't feel it. They produce burns. And they're going to have a wound. Now, why they are going to take longer to heal? You know, patients with diabetes mellitus, they taking longer times to heal. Why? Because the vessels are like this, small. And there's not enough oxygen and nutrients to repair the tissue who is being damaged. So that's why they are going to take longer time to heal. So that's why they put them in hyperbaric chambers. We have high pressure of oxygen. Chambers, we have high pressure of oxygen. That will help to heal faster the wounds. But the patient with diabetes mellitus most likely will not have actually that, they're not going to heal that easy your wounds. You like it? You like it? Okay, so excellent. So now you have the pathophysiology in your hands right now. Very strong, important tool. That is not explained as it is, exactly like it is as I'm explaining here. So you already know the concept. But now let's go beyond that. So if this is the only system that is going to be affected, the answer is no, because diabetes mellitus is systemic. Systemic, when I say systemic, means the whole body. When I say systemic, the whole body. One of the organs are going to be affected, are going to be the GI tract of the GI system. For example, the nerves that, for example, you have the CCK, the cholecystokinin. The cholecystokinin. Cholecystokinin, as you know, is being released by the duodenum in the presence of food or fat in the duodenum. The cells of the duodenum are going to release this hormone and go to the bloodstream, and the CCK go to the stimulate the contraction of the gallbladder and the pancreas. Now, we need nervous system. These nervous system are going to be affected by diabetics, in diabetic, because the vessels do not give the blood supply. So there is not enough nerve cells who are going to stimulate the contraction of the gallbladder. So you're going to not release. You have a lazy gallbladder, lazy peristalsis, lazy GI tract, lazy urinary bladder. So what do I mean lazy urinary bladder? You're going to retain urine because it's not contracting at the time that should be contracting, because the nerves are being damaged by or affected by diabetes mellitus because of this microvascular damage. And the same for the gallbladder. The gallbladder are not going to contract at the amount or the time that should be, so you cannot emulsify fats, so you can lead into diarrheas with malabsorption. So in diabetes mellitus, you can go from diarrheas if the gallbladder is being affected, or constipation if the intestines are going to be affected. So it could be diarrhea or could be constipation, depends. Okay? All right, so that is the pathophysio. So
Dr. G, can we take a break before we get deeper?
no, okay. All right. Okay, so you see, I was like in a toboggan already in the middle, and you make me stop. All right, that's fine. That's okay. Thank you, Nathaniel. All right, I'm going to freeze the toboggan. All right, so all right, I will see you lunch break, okay? Lunch break. Erica. Well, but you just, because she was eating already, so that's why she's not hungry. All right, so lunch break or no? Anna C, Anna A.
Yeah, that's fine.
See? Okay. All right. So let's do at 11:35. 11:35. Okay, sure.
Thank you.
Hello, at what time we said we are going to come back?
35.
35, okay. Thank you. Okay, are we ready? Tell me, what happens if I press a phone here? I never press it. Press this. What happens if I press this red button phone?
You leave the call.
Yeah, I know. The call
That's
button. To whom? Oh, leave call. So what does that mean? I don't know. Can we try? No, no,
It'll
no.
hang up the
We're just
call.
Sure.
The ones who are using cell phone?
you, Dr.
No.
G, you're
No,
gonna
you will leave Dr. G.
Oh,
It's like to end it.
call.
oh, okay. All right, so I should press? No, 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 right? Okay, no. All right. No, no, okay, Jacob. No. You want to make troubles, huh? Okay.
If you're
I'm
curious,
just
you can try.
hitting.
Okay, so let's continue here. Your cameras, Alejandra, Rinzin, Christian, Adriana, please. Adriana, Rinzin, Alejandra, please don't. 1 minute is important. Well, anyhow. All right, so talking about complications, now we are going to talk about please.
Dr. J, we can't see your screen.
Oh, sorry. Thank you. Alejandra, please, your camera. Adriana, your camera, are you there or no? Adriana?
Just got here, sorry.
All right, so let's start with the complications. So complications are very important to remember, please, okay? All right, so when somebody is telling you what complications are having, you can tell macrovascular and microvascular problems. So microvascular and macrovascular. So those are basically the complications. So macrovascular, why? Because in diabetes mellitus, what happened is excess of glucose in blood are going to produce damage on the endothelium as well. And that damage are going to produce regeneration of the endothelial tissue. And that damage are going to be area of deposit of atherosclerosis or cholesterol. So basically, it's going to accelerate the are going to produce deposit of cholesterol as well in the vessels. So that can produce atheroma, obstruction, etc., etc. All right. So macrovascular and microvascular. So what we need to remember, basically, the main problem that can produce all these retinopathy, nephropathy, and neuropathy, those are the three things that you must have it in your mind always, are because of microvascular complications. You can say microvascular complications. So in few words, you can tell everything that I explained to you in the few moments before. We okay with that? We all right?
Yes.
Okay. So complications, we have the acute complications. Acute complication is going to be the DKA. DKA is diabetic ketoacidosis. So I have I'm doing some simulation for DKA. So you will tell me what you want at the end, because we are going to do some simulations. Diabetic ketoacidosis. Diabetic ketoacidosis means that that is basically diabetes mellitus type 1. Type 1 can sometimes in diabetes type 2. Sometimes, but 99%, 95% of cases of DKA happen in diabetes mellitus type 1. Is that clear? All right. So what happened here? You don't have insulin. You don't have insulin. You don't have insulin. Glucose cannot get into the cell. Glucose cannot get into the cell. So the cells are actually hungry. They still need to have energy supply. It's like you are hungry for 2-3 days and you have a Band-Aid in your mouth. They show you the candy in front of you, but you cannot open your mouth to eat. So the glucose is there, but you cannot use it. So the cells, what they're going to do is the sources, or they're going to use the fats. Fat can produce 180 ATPs as well, but the fat, we go through the beta oxidation, and these fat are going to turn into acetyl-CoA. But the inconvenience about this is that they produce ketone bodies as well. Ketone bodies. There's 3 ketone bodies. So 3 types. We don't care about that. So, but the ketone bodies, what produce is acidosis, metabolic acidosis. All right, so metabolic acidosis can happen in any metabolic disorder. Diabetes mellitus type 1 is not the only one. Okay, so there's other metabolic disorders that can happen with this, for example, excess of lactic acid, etc., many others. So, but DKA is going to be basically metabolic acidosis. You okay with that?
Yes.
Okay, so in order to know, because metabolic acidosis can happen with DKA, they can happen with infections, they can happen with diarrhea, profuse diarrhea. So how do you know this metabolic acidosis is caused by DKA? For that, please pay attention to that. So we are going to know about the anion gap, anion gap, the anion gap, anion gap. Gap is gap, it's a space, empty area, right? Anion means negative. So anion gap, you're going to have here a high anion gap and metabolic acidosis. When you have metabolic acidosis, you need to check the anion gap. What is the anion gap? It's a full class about that, so I will try to do it as easy as we can. So anion gap is the gap of negative charges. So you're going to have actually positive charges, positive, and actually you have negative charges. So the difference between these are going to be called the anion gap. So what does that mean? So we have sodium and potassium as positive, and we have chloride and bicarbonate as negative. So normally the positive versus the negative are going to be actually equal. But mostly we measure the chloride and the bicarbonate as anions and the sodium and potassium as cations. And what happened is that there's other anions like sulfates, like phosphates, like albumin that they have a negative charge. So all these negative are not measured by the anion gap. So actually, you will see here that we have here the positive charges here, positive, and another square which should be all negative should be equal. But because we don't measure these actually are going to be what we call the gap. This negative is going to be the chloride and it's going to be the bicarbonate. But this gap should be measured. When you have high anion gap is because you have a lot of more negative charges. These negative charges are going to come from acids. Acid, all right? So for example, the lactic acid, we have the ketone bodies that are acid, and these lactic acids are going to be turned into lactate. This lactate is negative, for example, okay? The ketone bodies are negative too. So this anion gap is very high. It's very high. So very high, very high. So that means that you have high anion gap and metabolic acidosis. Okay? So now, how to remember that? How to remember that? You're going to remember that very easy. So please surprise everybody here with this. This is high level, okay? So just remember. So how we remember that? This is the high level I want you to share with you, is the high anion gap with metabolic acidosis. The patient is Hackman. So say Hackman one time, please.
Hagma.
So patient with diabetes, diabetic ketoacidosis, diabetes type 1, the most common, you're going to have Hagma. When you say Hagma, everybody need to understand that it's high anion gap metabolic acidosis. We okay with that?
Yes.
Yes.
Okay. We have here in DHHS or DHS is happening acute complication for diabetes mellitus type 2. And what is this? Is actually the hypersmolar diabetic. For a moment I was blank. diabetic hyperosmolar, diabetic hyperglycemic, hyperosmolar syndrome. This diabetic hyperosmolar syndrome happened only in diabetes mellitus type 2. So here you are not going to have a metabolic acidosis. So you will have a hyperosmolar. Hyperosmolar means the osmolality, so the amount of elements in your blood. So the amount of elements in your blood is about 280 millismoles per liter. And this is hyperosmolar, they can go up to 600. Why? Because basically you are dehydrated because of diabetes. So just remember, DHHS, remember diabetic hyperglycemic hyperosmolar syndrome occurs in diabetes type 2, and the DKA in diabetics type 1. Diabetics type 1 are HAGMA. And here we have, you can have metabolic acidosis some level too, but with not a high anion gap. A high anion gap, the gap is going to be 12. Basically, it's between 8 to 12. That is the value, but the cutoff for diabetes is anion gap 12. What is anion gap? Is the difference between positive and negative. When you have high anion gap, means more than 12, your gap of negative are higher. Why? Because you have more acids. You have more negative charges. Okay? So that is confirmed that you have diabetic ketoacidosis. All right, so in acute disorders, we are going to have acute complications. I didn't say signs and symptoms. The acute complications, we have DKA in diabetes type 1 and DHHS in diabetes type 2. You okay with that?
Yes.
Okay. So now, here we have the chronic diseases. Chronic complications, chronic complications. You just remember the word knife. Nephropathy, because of the microvascular problems. Neuropathy, because of the microvascular problems. Infections, you have high levels of glucose, and these glucose are going to be basically giving a problem for the growth of bacteria. Bacteria love glucose. Love glucose. One of the most common infections for bacteria is, for example, UTIs. UTI, urinary tract infection. Urine is sweet. Bacteria love sweet, start to grow. You have an injury, a wound on your feet, your toes. You already know actually why the distal portions are going to be affecting in the diabetes. One tip here: what is the knee? What is the? Oh my God! What is the below the? Oh my God! What happened? Elbow, knee, and the other one. What is the articulation of the foot? Ankle. Oh my God! The ankle. Your ankle. Below the ankle are going to be the lesions of diabetic patients. Above the ankle is going to be other stuff. It's going to be peripheral arterial disease, PAD. That is different. So most common, the lesion for diabetes mellitus are going to be from the ankle and below. Is that clear?
Repeat it one more time, Dr. G, the last part.
The lesions for ulcers for diabetic patients mostly are going to happen from the ankle and below, from the ankle to your toes. Okay, we got it?
Thank you.
Okay, don't forget that. And why is that? Because first of all, you have risk for injury. Why? Because you don't feel your feet. You don't have sensation. And when you have the wound, you have this microvascularity that is not going to allow to reach oxygen and nutrients to the area. So it's going to take time to heal, more time to heal. You okay with that? Okay. So
Yes.
then we have vascular diseases. Vascular diseases basically could be a combination of macro and microvascular problems. Coronary artery disease, cerebral vascular accident, PADs can happen too. Basically, that is the peripheral arterial disease, deposits of atherosclerosis on the arteries that can produce claudication. You did claudication in MedSearch already or no? Tell me, please. Yes or no?
No.
No? Okay. All right. So let's leave it that for MedSearch. And we have the retinopathy. Retinopathy, E as I. So eye retinopathy. All right. So that already, you already know what are the chronic complications of diabetes mellitus. Okay?
Yes.
All right. So in DKA is 250, sorry. DKA, you start to have DKA, and you can lead into coma and death. Same, some HHS, coma and death. So either way, the DKA in diabetes mellitus type 1 and HHS are going to be DHHS or HHS is the same, diabetes mellitus type 2. So here we have the glucose more than 600 and the glucose here in DKA in diabetes mellitus more than 250. So that is what you need to be aware. Okay, you already know the normal values of blood, of glucose in blood. So in the next exam, there is a lot of laboratory tests that you need to assess, okay, in order to know the intervention. All right? All right. So, perfect. All right, so why metabolic acidosis? Why no metabolic acidosis in HHS? There is no metabolic acidosis in HHS because for a simple reason. The reason is that you have DKA metabolic acidosis. Why? Because you don't have insulin at all. So you are going to use the fat in order to use the for energy. But in HHS, that is diabetic mellitus type 2, there is insulin, yes, and some receptors are going to still working. Not all the receptors in the body are actually useless. So some of receptors in diabetes type 2 are still working. So they're still using the glucose. So that's why that is going to inhibit the lipolysis. So they're not going to use fats. So that's why you don't produce metabolic acidosis in diabetes type 2. Is that clear or no? Is that
Clear.
very clear? Okay. Now, just to finish the concept here, because you're still telling me diet and exercises. Diet and exercises. We can talk about diet and exercises a lot, but let's go very simple. Why do we need to do exercises? Why do we need to do exercises? We need to do exercises, mild to moderate exercise in diabetes mellitus, because that produces a process that is two processes. One process is what we call is the angiogenesis. Angiogenesis. So mild to moderate exercises produce the angiogenesis. What is angiogenesis? Angiogenesis means angio vessel and genesis new, origin. So they are going to create new vessels, capillaries, arterioles, little by little. Why? Because your muscles are going to provide more oxygen. So the body starts to generate more vessels. And these vessels are new vessels, like a newborn. So they don't have any problem with the endothelium. They don't have any problem with the tunica media. They don't have any obstruction. There is no atherosclerosis. So that is going to help you to prevent complications in diabetes mellitus. Is that clear or no? And The other one, second, is that it's going to increase the number of insulin receptors. Insulin receptors. So that's why the exercises are going to be crucial for the treatment. I told you 95% of the treatment will be diet and exercises. You okay with that?
Yes.
All right, so now you got the whole, but part of what I want to tell you, there's other considerations about diet and all that we talk about nutrition before exercises, after exercises. That is not the topic today. So diabetes type 1 mellitus, secondary to destruction of pancreatic cells, causing insulin deficiency. Let's go to the second review of what we are talking. Is going to be an immune mediator. So what that means, that the immune system is going to destroy the islet of Langerhans. Basically, the cutoff is going to be under 30 years old. So diabetes mellitus, the cutoff under most likely is going to happen about less than 30 years old. But they can happen later on. Nowadays, in the past was very defined. Juvenile or juvenile diabetes type 1 and adult diabetes type 2. But now they're overlapping. So really that term of juvenile and adult are not going to still being in use in the next years. Look at the trend is going to be like diabetes mellitus type 1 and type 2, they can happen at any age. That is going to happen probably in the next 10 years, 20 years. All right, so now PPP. What is PPP? PPP are the signs and symptoms of diabetes mellitus. Signs and symptoms. The previous one we was talking about complications. We should talk about complications later, but anyhow. So the signs and symptoms of diabetes mellitus. What is that? P, polyuria. Polyuria. Number 2, polydipsy. And number 3, polyphagia. Polyphagia. Polyuria means excessive of urination. Polydipsy is a consequence of the polyuria, because if you pee a lot, you're going to be dehydrated. So the patient feels thirsty. Okay? And polyphagia, because the 100 trillion cells of your body are not receiving glucose. You are hungry. So your body thinks you are not eating, even though that you have a lot of glucose in your blood, you cannot use it. So when you're still very hungry, and the cells are going, and you start to feel hungry all the time, eating. Now, you're going to lose weight. Lose weight basically because you are using your fats. And second, because you are using the gluconeogenesis. And the gluconeogenesis is a major factor of decompensation of diabetes mellitus. So we have what? The gluconeogenesis that is going to turn proteins from your muscles. That is where mostly taking the protein for gluconeogenesis. And that are going to make you decrease weight and volume in general. So you're using fat, you're losing proteins, okay? And this is not associated with obesity. That is NCLEX. The one who is associated with obesity, metabolic syndrome, are going to be diabetes type 2, okay? Diabetes type 2, disease characterized by hyperglycemia. Yes, hyperglycemia. So they have PPP as well. Polydipsy, polyuria, and polyphagia. So those are the signs and symptoms. Listen to this. When I said signs and symptoms of diabetes mellitus, it's the same to say signs and symptoms of hyperglycemia. Yes or no?
Yes.
Okay, so don't miss that, okay? Many questions. This is high yield in all English and Hesse. All right, so diabetes mellitus type 2. Disease characterized by hyperglycemia and resistance to the insulin action, the receptors. Inadequate insulin secretion, this is another cause, and excessive inappropriate glucagon secretion. Glucagon, what is doing the glucagon? Glucagon, what is doing is taking the glycogen into into glucose. Remember, this is the glucagon. We have the insulin that is doing the opposite, the glucose into glycogen, right? So glucose gets into the cell, and actually the glucagon. So sorry, is going to say glucose into the cell, to say more precise, and actually it's taking glucose inside the cell. Meantime, the glucagon are going to take glucose from the cell outside into the blood. You okay with that?
Yes.
All right, so number 1, glycogenolysis. Number 2, gluconeogenesis. Number 3, increase of adrenaline. Number 4, increase of cortisol. Number 5, what? Increase of glucagon. And number 6, absorption. So these are the mechanisms that happen in actually in diabetes type 1 and type 2. Those are the mechanisms that are regulatory of sugar. So these are going to start. So if you have low levels of glucose in blood, if you cannot use your glucose because the cells are hungry, you're going to trigger out cortisol because you're and adrenaline because you're going to be in stress and fight or flight. You're going to increase the glucogenolysis. So glycogen are going to start mobilizing from the liver and muscles into the blood. Glycogen into glucose. Gluconeogenesis, that is the main thing here that produces the decompensation. The gluconeogenesis, turning proteins into glucose. The glucagon is going to turn, you have, the body thinks that you are not having, you're not eating. The body thinks that you don't have glucose in your blood. So glucagon is going to be stimulated to produce the release of glucagon, of glucose from the cell to the bloodstream. And number 7 is the growth hormone. Growth hormone, they have, I'm going to explain another time, but the growth hormone can release glucose in blood as well. Glucose in blood, the growth hormone. So we have 7 mechanisms that you need to remember for the exam. 7. One is table of 7. I will put table of 7. Okay? Mechanism regulatory of glucose. So we can call compensatory mechanisms of regulation of glucose. Okay? Either way, I will put a compensatory mechanisms. Why? Because you cannot use glucose. So the body thinks that you are not using, you're not eating. So all these mechanisms are going to be triggered that increase even more the glucose in blood. We okay with that?
Yes.
All right. So nervous system, kidney, cardiovascular, infections. I will put here gastrointestinal as well. Gastrointestinal. All right. So let's keep. Oh my God! All my animations are gone. Okay. Anyhow. All right. Counter-regulatory hormones or compensatory mechanisms is the other name. Compensatory. There are many names for the same thing. Counter-regulatory hormones. Glucagon, epinephrine, cortisol, growth hormone. Right? And actually, what is doing, these components are going to activate the gluconeogenesis, the gluconeogenesis, the glycogenolysis. Okay, all right. All right, so here we have the glucose. This is the level of glucose. Glucose in the animation was up to here. Then in the animation, I will make a click and the glucose go all the way up to here. And why is that? Because glucogenolysis and gluconeogenesis. Proteins and lipids, especially proteins, are going to lead into more increase of glucose in blood. Why? Because your body cannot use glucose. You think you're not eating, so the body starts to release all the glucose they can into the blood. We have the glucogenolysis that basically coming from the liver and muscles. So they are going to turn the glycogen into glucose. All right, so what happened here? Then you have excess of glucose in your blood. When you have excess of glucose in your blood, they are going to go to the kidneys. In the kidneys, what happened is the filtration are going to be, listen to this. There is supposed not to be any glucose in the blood, in the urine. Why? Because even the glucose is small, they can be filtrated and go into the proximal convolute tubule. The nephron is going to be able to absorb, all the glucose. As a consequence of that, there is no glucose normally in your urine. But what happened? So it's what we call the clearance of the glucose. Let's imagine you have a vacuum. You have a vacuum this size. And this vacuum, you're going to vacuum the dust. So you have some dust, oh, very happy, oh, yeah, vacuum, clean, okay, nice, right? But what happens if you have 10 pounds in this small vacuum, 10 pounds of dust? If you have 10 pounds of dust, the poor vacuum is going to absorb, and it's going to burn out. It's not going to absorb more because they have a capacity, a limit. Yes or no?
Yes.
Please follow me because that is encouraging me to do more. If you don't participate, I will just read the slides. Okay. So I don't know if you understood that or not. Okay. All right, so when you have too much glucose in your blood, the filtration is going to take a lot of glucose in the convolute tubules. But and the kidney is going to absorb all the glucose he can. He cannot absorb more glucose than actually the machine can do it. So when is that level? When your glucose levels, write down this, is more or equal than 110 milligrams per deciliter of glucose, you are not going to you're not going to be able to absorb all the glucose, and glucose start to appear in the urine. So your normal levels of glucose fasting is 70 to 99. In no fasting, you should be less than 126, 25, maximum 125. But if you are basically in fasting and your glucose is more than 110, your body are not able to absorb all the glucose, and you start to lose glucose into your urine. Okay, is that clear? Okay, all right. I've been telling you. All right, so we have a lot of glucose here because they cannot be absorbed. And what it's going to do is osmosis. Osmosis is going to bring water here because they want to keep the concentration in and out. So osmosis go from low concentration to high concentration. The high concentration of glucose are pulling water into the convolute tubules, producing an increase of urine, excessive urination. That produces polyuria. That produces dehydration, and the dehydration stimulates the hypothalamus in order to produce this excessive thirsty. So you start to drink a lot of water. So is that clear? Okay. So so you guide me if you want more or less. I'm trying to do my best here.
Hold on, Dr. J. So you have high glucose, then the water goes into the.
Convolute tubule. I don't want you to write down everything I'm doing. I just want to understand. Okay, so that is called osmotic diuresis. Okay, osmotic diuresis. All right. So then we have another thing that is going to produce is the fat are going to produce lipolysis, start to increase the fatty acids. These fatty acids coming from the liver, ketone bodies can be used by the brain. But remember, the brain need to use 24 hours 7 glucose. But basically, ketone bodies can be used by the brain in cases of actually lack of glucose in your blood. Ketone bodies are coming from the fatty acids. The fatty acids are going to produce three ketone bodies that produce, we don't remember the names, but there are many of them that are going to produce metabolic acidosis. So these substances called ketone bodies are going to be eliminated through the breathing. So you have this like apple smell, sweet breath. So you will speak, you don't need to put your nose in your mouth. You can smell it for 1 yard, 2 yards away from you. So it's going to be that sweet, pungent smell of apples. Okay. We have then metabolic acidosis. Metabolic acidosis, you have the pH lower than 735, and they are going to try to compensate. Too much acid, you're trying to eliminate carbon dioxide in order to decrease the strong hydrogens. And that produces what we call the Kussmaul breathing. Kussmaul breathing is going to be a very deep breathing and increase the respiratory rate. Okay? There are going to be potassium disturbances. Potassium disturbances are going to be when you have too much acid in your body, the buffers, especially hemoglobin in the red blood cells, are going to be working in this time. So what happened is that here, the red blood cells are going to have hemoglobin, and you have that excess of hydrogens. This excess of hydrogens means acidosis are going to be captured by the hemoglobin. But when they get into the cell, there's an exchange of potassium. Potassium starts to come out. 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 So you need to be careful with this. Why? Because potassium can be apparently higher in your blood, but what you have is a cellular dehydration. So that means the potassium is coming out from the cell. So, but overall in your body, overall, including the cells and the blood, you have hypokalemia. But apparently you have hyperkalemia, but it's false. It's not true, because actually the overall potassium is being lost because there is a shift of potassium coming from the cell outside of into the blood. All right, so I'm not going to ask you if you understand that or not. I'm trying to do my best. You don't care. I will keep going. So nervous system, we have neuropathy. We are going to use gabapentin. Gabapentin, as you know, is a coadjuvant it's actually for neuropathies. So neuropathic pains, gabapentin. Gabapentin can be used as well for what? For coadjuvant pain. All right, so gastroparesis. Gastroparesis is another term. It's coming for your NCLEX. Gastroparesis is gastro-stomach paresis, a slowdown. And actually, what is the treatment for that is that metoclopramide. Gastroparesis are going to produce an increase of gastric acid because your stomach is not going to evacuate the food as fast as before. The food is in the stomach that produces more gastric acid. So patients with diabetes mellitus type 1 or type 2 are going to have this gastroparesis. And that actually is treated with that metoclopramide. What is the metoclopramide? Metoclopramide is an antidopaminergic. Metoclopramide is used to decrease or to increase it's a prokinetic. that is going to stimulate the peristalsis, making the evacuation of the food from the stomach faster. In addition, metoclopramide is going to be used as anti-nauseous, not in this case, but metoclopramide is going to be used for control nauseous. And just remember, nauseous is DASH: dopamine, acetylcholine, serotonin, and histamine. So one of these treatments is going to be antidopaminergic. In this case, is the metoclopramide. Cardiovascular. Cardiovascular, there is many things that you need to remember about how to treat the patient with cardiovascular diseases. So first of all, you need to check that actually if the patient is less than 35 years old, they have, as you can tell, diabetic mellitus can produce electrolyte imbalance, especially for potassium. So you basically is more severe the DKA complication than the HHS. So the DKA, you must always check. So patients with hypertension. Why hypertension? 7% of the patients with diabetes mellitus in the next 5-10 years are going to suffer from hypertension. Why? Because the glycosylation. So glycosylation, the glycosylation that we explained in the previous class, in the previous hour. Glycosylation, you will see the thickening of the tunica media is going to basically produce a narrowing of the vessel. So it's not a vasoconstriction. It's not. It's what happened is the hypertrophy of the tunica media of the vessel. And that is equivalent to increase the peripheral resistance. It's equivalent to say that peripheral resistance increase. So that means that peripheral resistance increase, your blood pressure go up. So remember, blood pressure equal cardiac output times peripheral resistance. And the peripheral resistance is going to increase, not because of vasoconstriction. It's because the narrowing of the lumen, because of the thickening of the tunica media caused by glycosylation, or you can call the microvascular complications. All right. So for this question for NCLEX and for NCLEX and HESI pharmacology specifically, you are going to have that patient with hypertension without diabetes mellitus, you need to control your blood pressure less than 140/90. So that is considered that the patient is under control with hypertension. That is a patient with hypertension without no patient with diabetic
Dr.
mellitus.
Dr.
Yes.
G, you're kind of choppy. We missed some of the things that you just said.
Which
You
part?
were the last thing I heard was glycosylation. You were talking about that.
Okay. All right. So who is this?
Charlize.
Charlize. Yes. Tell me again if that happened again, please. Okay.
Okay.
Okay. So glycosylation. Glycosylation is going to make the tunica media are going to get thicker. So that is going to narrow the vessel. This is not vasoconstriction, but the effect is similar as vasoconstriction. So the size of the vessel are going to be in diabetic mellitus the same, but because of the hypertrophy or increased size of the tunica media are going to get narrow the vessel. And that is similar effect to increase the peripheral resistance. Peripheral resistance are going to increase the blood pressure, as you know. So this is caused by glycosylation. If you don't want to say glycosylation, you're going to say microvascular complication because of microvascular complication. Is that clear?
Yes.
Okay.
Yes.
So the goals for blood pressure. If you have a patient without no diabetic patient, just hypertension, that is the goal is have hypertension, but in addition,
You're breaking out again.
Breaking out again.
So I'm going to log out. Okay?
We
Everybody
didn't
me?
hear you, doctor.
And you said,
What I'm saying, I'm going to log out and log in again.
okay.
Okay, can you see me? Can you hear me?
Yes.
Okay, so it sounds better than previous.
Yes, Dr. G.
Okay. All right, so here we are going to talk about patients. We already talked about why the patient have hypertension, right?
Dr. G, you're not presenting.
Uh, Okay, can you hear me now? Can you see that?
Yes.
Yeah, we can hear you clear.
Okay. All right, so is that clear? So tell me why the patient have hypertension, diabetic, they have hypertension.
Because of
Why?
glycosylation.
Yeah, or you can say microvascular, microvasculature complication, right? Right. So simple as that. So you can engulf all the concepts in just in this problem. Microvascular complications, or you can say more elegant, glycosylation. Okay, so that means diminish the lumen of the vessel, causing increased peripheral resistance without having vasoconstriction. So they have the same effect of vasoconstriction. And in diabetes, it's not because the vasoconstriction, no. It's because the lumen is narrow itself. The lumen itself is narrow because of this microvascular complication or glycosylation. Okay? All right. So if you have hypertension, you need to treat it with ACE inhibitors. ACE inhibitors. ACE inhibitors. Question for the exam. ACE inhibitors. ACE inhibitors. ACE inhibitors is the angiotensin convertase enzyme inhibitor. And what it's doing is, remember the side effects: angioedema, cough, 30% of the patient. If you have cough, change to ARBs. What else? Electrolyte imbalance means hyperkalemia, ACE inhibitors. Another talk about ACE inhibitors is going to be, are going to protect the kidney, so it's not going to affect much the kidney. So that's why we select that for diabetes mellitus, because kidney is the problem, right? One of the problems. And ACE inhibitors is a good drug for that. Second, don't give to pregnants. Next, don't give it to pregnants because they can produce fetal malformations, especially facial malformations. And the next thing is, do not use aspirin with, because that is going to decrease the effect of the ACE inhibitor. Is that clear? All right. So now the goal for patients with hypertension, only hypertension, without any other problem, is 140 to 90. If you have a patient with hypertension and diabetes mellitus, your goal are going to be different. You need to subtract 10 millimeters of mercury for systolic and diastolic. So now your goal as a nurse, you need to memorize that should be 130, less than 130 over 80. That is the goal to control the blood pressure in patients with diabetes. Okay? All right, so coronary artery disease factors, of course, if you have these problems, microvascular complications, narrowing of the vessel, plus deposits of atherosclerosis. Why? Because of the glycosylation again. So atherosclerosis mostly happen in median arteries. So that is a macrovascular complication. Macrovascular complication. That's all. Microvascular complication, microvascular complication. That's all what actually you can tell in 2 words what is the whole complications of diabetes. We have hypertension. The obesity can be actually increase the problems with coronary artery risk disease, because these patients mostly they can die from cardiac arrest. Hyperlipidemia, you need to review your triglycerides, your cholesterol, the HDL and LDL values. And smoking, why smoking? Smoking is going to make it worse. Why? Because the smoke is going to go to your blood? No. Basically what is going to go are the toxins, the free radicals that are going to damage the endothelium, pushing the endothelium to regenerate. And that areas of regeneration are going to be the accumulation of atherosclerosis. All right, so kidney, yearly BUN, creatinine, microalbuminemia. So just remember when we was talking about anion gap. Anion gap we have here, if you remember this, please remember this. We have 1, 2 here and this, right? So we have here sodium, potassium, chloride, bicarbonate, BUN, creatinine. This is Chem7 and glucose. This Chem7 can be part of the BMP. BMP is the basic metabolic panel. The basic metabolic panel are going to include Chem7 and LFTs. So you can ask independently Chem7 or you can ask BMP. Okay? So now, if you see here, sodium, potassium, chloromagnesium. So these are the positive and this is the negative. So you make a subtraction, positive and negative, and that is going to give you the anion gap. Okay with that? Anion gap normally is 10 to 12. DKA, anion gap are going to be more than 12 in DKA. Okay with that?
Yes.
Nephropathy, thank you. Nephropathy we are going to use our favorite are going to be ACE inhibitors for the reasons I was telling you again. All right, so HIV, hemoglobin A1C, you need to give it every 3 months. That is nursing intervention, 3 months, to maintain the level less than 7. So just remember, so diagnosis of hemoglobin A1C is going to be more or equal 6.5. Okay, so below that is pre-diabetes. You need to know these values for many questions coming from next exam. And actually, your goal is to have it less than 7. Even though 6.5 is high already, but less than 7 is your goal to have these values. Check for thyroid gland disease. Why? Because diabetes mellitus, remember, are associated especially with Hashimoto, lupus, and celiac disease. in diabetes type 2 are going to be associated with metabolic syndrome. So metabolic syndrome can be affected the thyroid gland as well. So that's why you need to check thyroid gland. Very important part of your nursing interventions. Infections during cultures. Why? Why? Because UTIs are very common. Blood cultures, annual flu shot, now your COVID-19 including, and pneumonia vaccine in order to prevent complications during if the infection can happen. Okay? All right, so worst complications for diabetes mellitus type 1, DKA. And diabetes mellitus type 2 is the HSS. It's different. So it's called, we have, what is that? We have hyperglycemia, hyperosmotic, no what?
Isn't
No, it's I guess, right? Well, anyhow. HHS. So this is actually no.
Is it hyperosmolar hyperglycemic state?
Yeah, syndrome.
Syndrome.
So the name is hyperglycemia, hyperosmolar syndrome. Okay, is most commonly is HHS. Okay, HHS. All right. So nursing considerations. Yearly exam for cataracts or retinopathies. Yearly foot examination, patient inspect daily. EKG if patient less than 35 or have heart disease. Coronary artery risk factors, hypertension, obesity, so everything that we put in the previous slide are here. So I'm not going to repeat it. So in this slide, the previous 5 slides are summarized here. All right, so diabetics type daily injection. So we are going to talk about the treatment for now diabetes mellitus. There's many more things to talk, but definitely, yeah. So let's go directly to the treatment. Okay. So we have the treatment for the diabetes mellitus type 1. So I'm going to go, first of all, to the medications. Okay, so let's see here. Oh, I'm going to come back to this. Diet exercises, 3 months. So you have every 3 months you need to check to evaluate the patient. We have some metformin that is for diabetes type 2, acarbose that increase decrease the absorption of glucose. So this is misplaced. So sorry for that. So let me go here. All right. So let's go to the classification of diabetes mellitus. We have diabetes type 1, type 1 diabetes. We have diabetes type 2. We already know. Is diabetes mellitus type 1. Is diabetes mellitus type 2. You can say mellitus in both cases. Okay? Or you can say diabetes type 1, diabetes type 2, either way. Or juvenile or adult. We have gestational diabetes. That is not the scope for this. This is a whole class about gestational diabetes. Basically, it's the placenta who is the problem. And that can produce an increase of glucose available for the fetus, making the patient basically, the baby grow much bigger than should be. So in this case, the indication will be C-section. All right, so we have other, that is diabetes insipidus. Diabetes insipidus is not the scope of this class because diabetes insipidus is called diabetes because they have polyuria. You have little amount of ADH in diabetes insipidus. You have little amount of ADH. So actually you cannot reabsorb water, so you lose a lot of water, look like it's polyuria, similar as diabetes, but that deficiency of ADH or diabetes insipidus means no taste, insipidus, no taste. So the urine does not have any glucose. And that is the only thing similar to diabetes mellitus, the polyuria. and polydipsy too, because they are drinking, but there is no polyphagia. Okay? Nursing diagnosis, we have risk for infections. We already know why, right? So is that when you have the infection, it's going to be more difficult to heal. So pneumonias, wounds in the feet, ulcers, etc., are going to basically have presence of glucose that are going to increase or accelerate the replication of the bacteria. So that's why they have more risk for infections than regular person. Risk disturbed for sensory perception, that is another nursing diagnosis. That is when the patient is typically telling you, ankles hazy, they're telling you, I'm walking over cottons. And that is because you're losing sensitivity. Imbalanced nutrition, less than body requirements. So the patient is afraid to eat, or they are not eating properly. So the nutrients are not going to be absorbed adequately or in adequate way. Deficit fluid volume. Why? Because you pee a lot. You pee a lot. You pee a lot. You pee a lot. And that leads into dehydration. Are going to deficit fluid volume. Fatigue. Obviously, you cannot use glucose to produce ATPs. So you start to have this weakness. And how is weakness or fatigue? What does it mean? How you feel, how you tell the patient is weak. The patient is weak when the patient is telling you that I feel like I'm lifting a weight all the time. I feel heaviness. So that is the way the patient is telling you. You can recognize the patient is fatigued or weak. I feel my body is very heavy. So that is classical, typical, telling the patient when the patient is weak. All right, so let's see. This is diet. I'm not going to go on that. This is the hypertension or diabetes mellitus. So we need to control hypertension without diabetes mellitus 140/90, but diabetes mellitus with hypertension less than 130/80. All right, so maintain the BMI. The BMI should be less than 25. Less than 25. So that means in the normal rate. So that is the best BMI you can have in patients with diabetes. Talking about hypoglycemia is when the normal values on fasting is 70 to 99. So hypoglycemia when it's less than 70. All right, so what are the causes of what are going to signs and symptoms of hypoglycemia? Are going to be tremors, clammy sweating. What is clammy sweating? Clammy sweating is like a cold sweat. So how you recognize it's a clammy sweating? You are sweating? No. Right? Because the temperature is okay and nobody's sweating around you. The only one who is sweating is you. Okay? You have fever? No fever. All right, that is clammy sweating. Simple as that. Tremors are going to be used for hypoglycemia when somebody is taking beta blockers, especially the Inderal or propanolol, that is a non-selective beta blocker or beta antagonist. You can say beta antagonist, beta blocker, or beta 1 blocker, or beta 1 antagonist. Okay, so beta blocker is already, we don't have beta 2. So what happened? That beta blocker are going to treat tremors. When they treat the tremors disappear. So when you have hypoglycemia, you don't know that you have tremors. So they are hiding signs and symptoms of hypoglycemia. I'm not saying that beta blocker cause hypoglycemia. No. Beta blocker, what is going to hide, mask the signs and symptoms of hypoglycemia. Okay? Early signs of hypoglycemia are going to be the tremors and clammy skin, sweating, clammy skin. Later are going to affect the nervous system, and you start to have hypothermia. They are going to, in NCLEX, HESI, many questions I saw about diabetes is double vision. This is money in your pocket, right? Double vision. Later, signs of hypoglycemia. All right, so if unable to swallow or unconscious, administer glucagon. So that is one of the treatments. Glucagon, there you are. If you are hypoglycemic, they're going to apply glucagon. Glucagon is remove the glycogen into glucose into the blood, and actually the problem is resolved. All right, so we have problems of these complications are going to be the no adherence of the patient to the regimen or to the treatment. So stress, you already know that's a trigger, right? That is going to elevate your glucose in blood. Pregnancy, surgery, other infections, I told you that can lead into increase of sugar, hyperglycemia. All right, so hyperglycemia, polyuria, polydipsy, polyphagia. Well, there's other rainbow of problems here. So if you have high hyperglycemia in DKA, when you have DKA, diabetes mellitus type 1, more than 250, that is a problem. You start to produce ketone bodies. That is another topic. Ketone bodies. These ketone bodies are going to be seen in the blood test, and the urine. Okay, when you have what diabetes HHS, your glucose should be less than 600. So what is the difference? Why? Because when the patient you have more than, listen to this very careful, and DKA is more acute than HHS. So it's more abruptly presentation the DKA than the HHS. In DKA, when you are having too much glucose, you have hyperglycemia, you have osmotic diuresis. So you are losing fluid, you are dehydrated. Okay? All right. In HHS, the process is more slow. It's going to take about 1 day, 2 days in order to show signs and symptoms. So in DKA, in 24 hours, you are going to the hospital because you feel miserable, right? You feel like low levels of consciousness, etc. Right? So in HHS, the patient is going to the hospital in about 2 to 3 days. So, and the dehydration on the HHS is going to be higher because you have more time to go. When you initiate the symptoms, you are actually taking 2 to 3 days of dehydration. So your blood is more concentrated. So the glucose are going to be hemoconcentrated. So that's why HHS is going to show as 600 milligrams per deciliter. Meantime, DKA is more abruptly. So when you go to the hospital, they're going to check that basically the 250 milligrams per deciliter is, you are dehydrated, but you are more dehydrated with diabetes mellitus type 2 because it's taking more time to go to the hospital. You okay with that?
Yes.
All right. So let's go now to the drug. What time is it, please?
12:44.
Okay. 12:44. All right, so I need you fresh minds. So we are going to start talking about the drugs itself. All right, so I'm going to give you 10 minutes break. And actually, if any comment or anything, let me know. Thank you.
Thank you.
Thank you.
You're welcome. Guys, you know how much I can give you more. So please, just participate. No, I'm not going to say a word. I'm going to start fresh in the next 10 minutes. Okay? 5 minutes before 1. All right, so we have 1 minute. Okay. Cameras on, please. I hope that you're enjoying this journey through diabetes mellitus. I hope you enjoy it. If not, I don't know. I'm going to just have nightmares tonight. Okay, so let's get started. Is your cameras on, please? Okay. There you are. All right, so let's talk about the insulin. Insulin is a big topic, okay? And talking about the insulin, listen to this. We have 4 types of insulin, okay? The insulin are going to be rapid, or called analog, are going to be the log, human log. We have the short acting, or regular, or R. So when you see R in the bottle, in the container, that is short or regular. You need to get familiar with these 3 names. The intermediate, that is basically similar as the regular insulin, the normal insulin that you secrete in your body, are going to be the intermediate, and actually is the MPH, or called the N. And we have the long-acting insulin. So to start, we need to remember rapid, short, intermediate, and long. Okay? All right. So how to remember that? How to remember that? I want you to remember this mnemonic. Rush in your legs. Rush in your legs. Rush in your legs. Rush, R-A, means rapid. S-H means short. I-N is intermediate. And long legs, leg, long action. You okay with that?
Yes.
Now, I want you to think about those names. Put rush in legs in your mind, and try to repeat it yourself without saying anything, just mentally. Rush in legs. R-A, rapid. S-H, short. I-N, intermediate. Leg, long acting. Okay? All right. You okay?
Yes.
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 Okay, thank you. All right, so we have the rapid, the onset. Onset means how soon is going to be acting, how fast. That is going to be basically the 15 minutes. The short are going to start between half an hour and 1 hour. Intermediate are going to start about 2-3 hours. And the long start to go in 1 hour, start to make action. Okay, leave it like that. So what I want you to remember about this is the rapid onset. The rapid onset. That is basically about 15 minutes. That is NCLEX. They will not ask you that commonly these ones, but I'm guiding you. NCLEX, HESI, they like to ask you about the rapid. 15 minutes. 15 minutes. Now, what is important and what they like to ask you in NCLEX and HESI is about the peak. What is the peak? The peak of the insulin. The peak of the insulin is this. Look at this. The peak of the insulin is if you have, for example, the rapid insulin, the insulin are going to go up, 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 up here, and here is the peak. That is where the highest concentration in blood is going to be reached. So when the peak of the insulin is here, that means that you have a lot of insulin, the maximum insulin that that medication can give you. And that is the moment where mostly all the glucose are going to get into your cell. The majority of glucose are going to get into the cell. So then the normal lifetime of the insulin, rapid in this case, are going to go up, and then the concentrations are going to go down. Because they are going to the duration is about 3-5 hours, 3-6 hours, 18 hours, depends. Some of these, the peak, for example, in the rapid is like this. In the short are going to be after 3 hours. The intermediate is going to be after it's going to last 18 hours. So the peak is going to take longer. And actually the long is the one who do not have any peak. It's going to be permanent, constant. After 1 hour, it's not considered, but actually 24 hours. That is going to last 24 hours, the long acting. All right, so what they're like to ask you in NCLEX and HESI is about the peak. And that is what you need to actually be very aware about the peak. Why? Because if you have could be rapid, short, intermediate, they're going to have a peak here, then the insulin concentration start to go down. But it's here in this point where mostly the maximum action of the insulin is going to occur. So that means that all the glucose are going to get inside the cell. So what happened after this point? So after this point, they are going to be decrease the insulin, but here we have all the glucose are being absorbed mostly. So this area is going to be risk for hypoglycemia. So that's why they like to ask you about the peak, because you take the insulin and you need to check about how soon is going to be a risk to show hypoglycemia the patient. And if you have hypoglycemia, you start to have shakiness, tremors, and actually you start to have sweating, clammy sweating. So what you're going to do in that case is give some sweets, some candies, in order to prevent the hypoglycemic state. Is that clear or no?
Yes.
Yes.
Okay. All right, so that is important to know the peaks. So you need to know all the peaks, but I have a way to remember this. All right, so I want just you to do this with me. Okay? So do you have rush in leg in your mind? All
Yes.
right. What is RA?
Rapid.
Rapid,
The second is going to be,
short,
Short.
and the I will be
intermediate.
Intermediate.
intermediate. All right? Intermediate. So the peak, there is no peak in the lung. There is no peak in the lung. Okay? All right. So now look at this. Short leg, short in leg, short, SH. Touch your nose, please. Touch your nose. Okay? Now, SH. Keep it. So keep now SH is short. Put your two fingers in your eyes. All right, and now intermediate are going to be your ears. Okay? Okay, let's start. So how many noses you have, Erica? You thinking?
One.
One nose, right? That is the rush, rapid. One nose, 1 hour. The peak. Rush, short, SH. What is the next? 2 eyes.
2.
That means peak 2 hours. And the intermediate, that is the next in, is your ears. You can, if you draw an 8, looks like an ear or no? So 8 hours is the intermediate. Excellent, Jacob. And the long term, long acting are going to be, there is no peak. Is that clear? So you already know that. All right, don't forget that. Okay? So 1, 2, 8. 1, 2, 8. No, not that like that, Erika. No. Okay. All right. Excellent. All right. So now there is actually a other, I would say, places that they make some variation of those hours, right? But definitely that is on the range. Nobody can tell you that it's wrong. So that is 1 hour, 2 hours, and 8 hours. Don't forget, that is not the onset. That is the peak. That is the peak. You okay with that? Okay. All right, so that is about what we want to talk about, the insulin. And let's talk about, see, look at this. So one nose, 2 eyes, and the 8 that looks like an ear, right? So 1, 2, 8. We have the rapid, the short, and the intermediate, okay? All right, so let's talk about the rapid. The rapid, I just remember, if you put here a log, this is a log. Can you see this log here? And put it down the hill. The log down the hill are going to go down very rapid, very rapid, very rapid. This rapid is actually the log, Yuma log, Nova log, Novo log are going to log are going to the rapid. Just remember the log down the hill. You okay with that?
Yes.
Okay. So we have the type of insulin. Short acting is the next, right? Short acting is going to be 2 hours, the peak, right? So it's going to be short, or regular. Remember, short. So I'm going to use my Latin accent. Short, regular, R. Okay, so that is the short acting or regular insulin. Sometimes they call the fast acting. That is different from the previous one. That is the rapid acting. Okay, be careful with that. All right, is the usual insulin be dose IV? So it's the regular insulin that we use as IV. The rest are going to be subcutaneous, right? So, but this is the IV dose. We use this in cases of DKA or HHS. Okay? All right. Intermediate are going to be intermediate. Intermediate. Humalin N. You can have Humalin R, see? But Humalin and Humalin N and R. So, but the difference is the R is the regular. The Humalin, they need to say N, right? All right. NPH, the name of NPH is the neutral protamine hydrochloride. That is a lab or something. So that is what is coming from the word NPH. All right. So this is supposed to be done here. Go away. All right. So after you drawing up the regular and the intermediate, so they're going to mix regular and intermediate. So what are the way of to treat? And that is because I was actually trying to do the thing. I mean, in the morning. So, all right, so we have the treatment for diabetes mellitus type 1. This is not basically very easy finding in the book, so please, okay, pay attention. We have two groups, the basal and the bolus. Sometimes it's called the prandial. The prandial means food. So that means that you're given before the food, before meals. Okay? So when you inject before meals, you need to have your food ready. Because as soon as you're going to take the injection, your food should be ready. You cannot wait more than half an hour. So because the peak is going to be in 15 minutes. And that is what we are going to use is the rapid acting, rush, right? Rapid acting. That is going to be the Humalog. All right. It's called prandial or bolus. Basal. What is the basal? All right, so look at this. Here we have 24 hours. 24 hours. All right, so here we have that basically your glucose levels, you want to keep it in this level, like this. That is what you want to keep your glucose levels during 24 hours. A little bit variations, of course, right? You don't want to have your glucose in this area too high. No. So that is why we are going to give this medication. All right. So which medication we are going to use? We are going to use two medications. One is the rapid, and the other one is the long-acting. Rapid and long-acting. So the dose are going to be based in units. And the dose is going to be 0.3 to 0.5 units per kilogram per day. Kilograms per day. All right? So once you have your calculation on how many units you're going to have per day, right? So basically it's going to be about 15 to 50 units, about. Depends on the weight of the patient. All right. So when you calculate the amount of units that you have in a day, you're going to divide it in 50%. And 50%. This 50% is going to be the units for the long-acting. And the other 50%, you divide it in 3 meals. So it's going to be 50 divided by 3 is about 3 parts, right? About, let's make it like 15%, this 16%, 17%. So you divide it by 3. And that depends on the meals. These are the rapid acting. The rapid acting or the rapid action, okay? The Novalog, Humalog, etc. So what you're going to do is to use the long-acting at night, injection at night. That is going to last 24 hours. And the rapid acting, you're going to have 3 meals, breakfast, whatever, lunch, and dinner, okay? And you divide these units and you will have the injection of the rapid acting 15 minutes or just before meals. So meantime, the long acting is working the whole day, okay? So you're going to, before meals, you're going to apply an injection of the rapid acting. You okay with that?
Yes.
Yes.
Okay. All right, so they are going to use some mix too, but the mix is 730, whatever. So they are actually a combined, right? So we have a combination of 70 units, 30 units, the whole content, and the only purpose of that is to decrease the number of injections per day. Decrease the injections per day. So instead to have 3 injections per day or 4 injections per day, you will have only 2. But they have some inconvenience because you cannot control the glycemia. What is glycemia? Levels of glucose in blood. As much as in this way, you control much closer your levels of glucose. Just remember the rapid acting. So after the rapid acting is 1 hour. So you have peak of 1 hour. So in 1 hour, actually, you need to check if you have signs and symptoms of hypoglycemia. How to prevent one? You need to always have some candies in your pocket. Okay? You okay with that?
Yes.
Yes.
Okay. All right. So we are going to see the. All right. So we are going to see that sometimes they mix the intermediate with a regular insulin. Intermediate and regular insulin. Intermediate and regular insulin. So when you are doing that, all right, so you're going to, after drawing up the regular plus the intermediate, you need to administer the medication in the next 5 to 15 minutes. You cannot leave the syringe there forever until tomorrow or keep it until tomorrow. No, because the regular binds the intermediate and decrease its action. You okay with that? NCLEX question. Okay? Okay or no, please?
Can you repeat it one more time, Dr.
Yes, please. Can you repeat it?
Sometimes you're going to mix insulins. You're going to mix the regular with the intermediate. R is the regular and N is the intermediate. The regular intermediate, when you prepare the syringe, is ready to administer to the patient. When you're going to apply the injection, you need to give it the injection in the next 5 to 15 minutes. Because if you wait too long, after 15 minutes, the regular insulin are going to get attached or bind to the intermediate. And that is going to decrease the effectiveness of the activity of the insulin. You okay with that or no?
Yes.
Yes, thank you.
Sure. All right, so intermediate acting. So what we are going to do, never, please, NCLEX, never shake the bottle. Never shake the bottle. Never shake it. Never, never, never. So when you are going to, actually draw the insulin, never shake it. Why? Because they create bubbles. And when you are draw the insulin is going to be bubbles inside the syringe. And that is not going to give a precise measure of what you're going to give to the patient. Okay?
Yes.
Okay. Thank you. Before administering, check signs and symptoms of hypoglycemia. Yeah, of course, you're not going to give insulin if the patient is hypoglycemic. You need to check or monitor the glucose before every time you're going to apply an injection of insulin. Sweaty, clammy sweating, tachycardia, confused, or glucose less than 70 milligrams per deciliter, milligrams, I didn't say grams, milligrams. If that is the case, you need to hold the medication. All right. So how we are going to do the injection? Look at this. You're going to put air into the cloudy. Who is cloudy? Cloudy will be the intermediate. Another cloudy will be the long-acting. But we are not talking about the long-acting. So only the rapid, the rush are clear. Rapid and short, right? Those are clear. The rest are cloudy. So in order to put to draw, you're going to put air on the intermediate syringe bottle first. Why you put air? Because when you are turning down the bottle, the pressure that you put air inside is going to help you to pull or to draw the insulin into the syringe. Is that clear?
Yes.
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 Okay. So then you're going to put air into, number one, you put air into the cloudy. Then you put air into the regular, into the clear. Regular, you remember, regular are clear, right? The first two are clear, the next two are cloudy. So we are using regular and intermediate. Or the regular is clear and the intermediate is cloudy. So you put air in the cloudy, take the syringe out, you put air then in the regular, that is the clear, and then you're going to draw, first of all, the clear insulin. So the second time you put the needle in the second bottle, that is the regular, you don't take it out, the needle. You just turn it upside down in order to draw the fluid. So you're going to draw the clear first. And then you're going to draw the cloudy. Okay? So you draw the cloudy. How to remember that? You're going, right now, we are NR, but you're going to turn into RN. Okay? So NR to RN. NR to RN. So what does it mean? We have, first of all, you're going to go air, the first part, air into the intermediate, then air into the regular, and then draw from the regular and draw from the intermediate. Okay?
Yes.
Never forget this, please, okay? All right. The long-acting, the determere, or Lantus, is used as a basal dose. What is the basal dose? Basal dose is because that is going to keep the glucose not to be high all the time. The long-acting is going, instead to have your glucose like this all day here very high, this lanting is going to make the levels of glucose this area, this level. So they're going to prevent hyperglycemia. That is the importance of the long-acting, 24 hours, give it at night. Okay? All right, so no peak and duration 24 hours. So question for NCLEX. Do not mix long-acting with any other insulin. Are going to be deactivated. Disaster. Okay?
Yes.
All right. Okay, so this is emergency. I'm not going to go on that. This is actually DKA and HSL. All right, so pre-mixed insulins are usually prescribed for patients needing a simple insulin treatment plan and sliding scale therapy. A sliding scale therapy is telling you that they have, they're going to have 2 injections in a day, and the dose depends on what is your glycemia before you take the injection. If your glycemia is higher, you need to have a little bit more insulin. If your glycemia is lower, so you have a scale table. And depends on that scale given by the physician, that is how you're going to withdraw how much medication you need. Okay? Mostly these mix are going to be in order to decrease the number of injections that you have in the patient per day. It's more difficult to control, so that's why we are going to use in initial, patients who start to have, they can still controlling somehow the hyperglycemia. You can use this mix. Okay. Okay. All right, so we need to, this is all NCLEX. Rotation injection sites to avoid atrophy or hypertrophy of the fat. That is called the lipodystrophy. When what is lipodystrophy? So you pass your hand over the skin and you see that it's even, right? But when you have lipodystrophy because you are using the injections in that area, the fat starts to shrink and you see like a small bumpy area. So it's a hardening. So it's like a shrink. Is that fat are going to decrease. And what happened, the absorption are going to be affected. So you need to rotate the injections. So we need to have the same location as you read here for about 1 to 2 weeks. 1 week is recommended. You can go up to 2 weeks. And at least every area, so each injection should be at least 1/2 to 1 inch away from the previous one in order to prevent the lipodystrophy. Remember, this is for life. It's not going to be, yes, I feel good, I'm okay, I forgot. No, it's going to be basically for life. All right, so that is the NR, air, into RN, draw. Okay?
Yes.
Excellent.
Yes.
Once insulin is open, you need to store. This is another high yield NCLEX question, okay? Store at room temperature for at least, you can keep it for a month. After that, they can lose the potency, or actually, if you don't refrigerate it, they are going to lose the effectiveness of the medication. If surgery, another question, pre-mix insulin just before surgery. Actually we have less dose at pre-surgery. Why? Because the patients for surgery need to be fasting, right? So they don't have glucose. So the insulin obviously need to be lower, about 50%, 75% of the regular dose that the patient is having every day. So 1/2 to 1/4 in the morning, following by 5% dextrose, preparing the patient for the surgery. 5% dextrose IV, okay? And frequent checkup of glucose. All right, so date the insulin bottle after opening. So you can write down when was opened and when it's refrigerated. You count down 4 weeks, no more. Don't freeze it. Why are you going to freeze it? It's a protein, it's going to be totally denaturized. Do not shake insulin, can roll vial gently in palm of the hand to warm and resuspend. So they are going to actually mix everything, but without shaking. Don't shake it. Always you need to roll it like this. Roll it like that, okay? Roll it. All right, so any questions so far?
No.
Okay, so how so far, Gerald? You like it? You like diabetes? You like diabetes, okay. And you sisters, Erica and Alejandra? You like diabetes? Okay, so I will give you time until 1:05, a break, it's the last break, and we are going to continue with the diabetes mellitus type 2.
Dr. G, it's 127.
Oh, 127. Oh my God. Okay, no break. No break. No, sorry. Who said that? My God, I was thinking 12:27. Oh my God. Okay, so what happened? I have hypoglycemia. Okay, so let's keep going. So break, okay, break pass already. So put in your mind you have break already, mentally, okay? So you rest, you're fresh, let's continue. All right, so let's talk about the oral antidiuretic, oral antidiabetic. And with that, we finish this part, yes. Next class is going to be, we are going to talk about schizophrenia, anxiety. That's very good class. Okay, so Erica, can you remind me about Somoji and Down phenomenon? Somoji. Just tell me Somoji at the end, okay?
Samoji?
Yeah.
Okay, Dr. G.
Okay, yeah, I trust you, huh? Okay. Oh, all right, so here we have oral anti-diabetic medication. Oral anti-diabetic medication are going to be oral enteral medication, correct? And that are tablet pills, of course, right? So, and as we already discussed at the very beginning of the class, is the pathophysiology of the diabetes type 2 are going to be to decrease. We want to decrease the levels of glucose in blood, right? If you give insulin to diabetic mellitus, or I mean, a common diabetic mellitus type 2, the insulin is not going to do anything. Why? Because you have insulin resistance. Yes or no? So the solution is not to give insulin. The solution is to decrease all these counter-regulatory mechanisms. What are these counter-regulatory mechanisms? Mechanism of compensation mechanisms are going to be the glucagon, the somatotropin, we have the adrenaline, we have the cortisol. And that is going to lead into glucogenolysis, gluconeogenesis, right? They are going to lead into lipolysis. And actually, we want to prevent that. All right, so number one. So just remember that we have, remember, promote exercises. And I will tell you one more time here. If you are doing exercises, okay, and if you having your glucose, before you do exercises, you need to check your glucose. And your glucose are going to need to be less than 100. If your glucose is, should be 100, about 100. If your glucose is less than 100, before you go to do exercises, you need to take some orange juice glass, okay, or a couple of candies. That's it, okay? Be careful with that. So you're going to eat oatmeal, because when you are going to eat, you don't want to eat complex carbohydrates. You want to eat complex carbohydrates, and you don't want to eat simple carbohydrates. You don't want to eat simple, but you want to eat complex. Why you want to eat complex? Complex basically are going to be some potato starch, right? And especially the oatmeal. Oatmeal in the morning is very good. Why? Because what happens when you have, listen, what is going to be absorbed faster? The monosaccharides or the polysaccharides?
Mono.
Oh no.
Mono, right? If you have the monosaccharides, they can absorb very fast. So you can have peaks of hyperglycemia very fast. And then you have, down the hill, you're going to have hypoglycemia. And you don't want to have these peaks up and downs, up and downs. You don't want that. So complex carbohydrates like the oatmeal are going to take longer time to break down. And the oatmeal, this is what we call a soluble fiber. Remember soluble fiber? These soluble fiber are going to be like a mucus, right? That is covering the stomach and the intestine. That is going to decrease or slow down the absorption of glucose. What you don't want to do in your diet is to have fast absorption. You don't want that. You want a slow absorption to keep the glucose steady. So, and the oatmeal is going to do that. The complex carbohydrates are going to do that, are going to make a steady absorption, slow but steady absorption of carbohydrates, avoiding those peaks of hyper and hypoglycemia. Okay, all right, so let's go to the oral hypoglycemic medication. You need to do about 150 minutes exercises per week. You divided the 150 minutes in whatever you want, half an hour, 1 day, 9 days, whatever. So that is the recommended exercises amount. All right, so let's keep going. All right, so as we already know, the oral anti-diabetic medication, they have many names. I'm going to, based on the reviews I make in HESI and NCLEX, I'm going to guide you what are coming, what is not. All right? So I'm going to tell you and remark what's most likely coming. All right, so for that, we need to understand how we are going to decrease the glucose in blood. Number one, we can increase or stimulate the pancreas to produce more insulin. So more insulin. Remember, in diabetes type 2, we have resistance to the insulin, but not all the cells, all the bodies, not all the systems, not all the receptors are low sensitivity. Some of them are going to work, especially the ones who are in the muscle. So that's why when you're doing exercises, you're doing exercises, you need more oxygen. And the body, what it's doing, creating new vessels and new receptors. And that is going to help you to actually control your diabetes. So insulin secretion are going to stimulate the beta cells on the Langerhans islet in order to produce more insulin. That increase of insulin are going to actually control the levels of glucose in blood. They're going to decrease the glucose coming from the liver and muscles. So how we are going to decrease that? You decrease the glucose release from muscles and liver, blocking the glycogenolysis. The glycogenolysis. Glycogenolysis means glycogen into glucose. So we prevent that. We are going to prevent the absorption of glucose. So we can block the absorption of glucose at the level of the intestine. That as well is going to decrease the glucose in blood and decrease the glucagon. Glucagon are going to be released in fasting state. And the body thinks that you are in fasting state because the cells do not receive any glucose. The glucose is in the blood, very high, but nobody can use it. So the body thinks that you need to release glucose into your blood. And that is where glucagon is going to act. Glucagon produced by the alpha cells in the islets or Langerhans are going to remove glycogen into glucose, put it out into the bloodstream. All right. All right. So patients who, another concept here, diabetes mellitus with patients with NPO. NPO means nothing per mouth. Nothing per mouth means not even water. You know that very well, right? Not even water. Not even water. For surgery, at least you need to be 8 hours without anything by mouth. Why they don't want you to receive anything by mouth? Why? Because they want empty stomach. Why they want empty stomach? Why they want to have empty stomach? Because during for example, surgery, in the surgery, they are going to intubate you. They are going to have intubation. That intubation is a device that are going to go all the way back through the throat, through the posterior wall of the pharynx. And that stimulates the vagus nerve to produce this gagging reflex, and you start to vomit. If you vomit, that fluid that is in the stomach can go to the respiratory tract, and you end with aspirative pneumonia. And you don't want that. So that's why you want to have NPO. Nothing, you start having the gag reflex, but nothing is coming out because you didn't eat anything. That's good. So now, if the patient is getting into surgery and they are going to do NPO, and the patient is diabetic patient, so they need to take the medication. So what you need to do is to contact your healthcare provider. Easy as that. So what to do, right? How they are going to give the medication. Because notify that, the doctor notified the surgeon. So they need to be careful with the intubation, okay, for example. Okay? Now, look at this. Oral anti-diabetic medication, no impregnants. Not impregnants. Oral, no. Oral, no impregnants. Oral anti-diabetic medication. I'm going to take advantage of that. I'm going to open a different chapter of the book, and I'm going to talk about, very brief, about warfarin, that is Kepda-Cow, remember? Warfarin, Coumadin, and we have the heparin. Warfarin and coumadin is only PO. There's no other presentation. And heparin is going to be subcutaneous IV, and never intramuscular are going to be parenteral. So basically IV subcutaneous. So parenteral. So it's not enteral, it's parenteral. Parenteral means parallel to the enteral. So it's actually another route besides the GI tract. So PO, never impregnant. Never impregnant. Heparin, yes, impregnant. Okay? So I put it together here because I want you to remember these two things. Warfarin, PO, coumadin, oral antidiabetic medication, no pregnant. Heparin, parenteral, and insulin, parenteral, of course, are going to be yes for pregnant. You okay with that? Because you cannot, if you give to these two patients, the fetus are going to be hypoglycemic because they can pass the placenta barrier. Okay?
Yes.
Yes.
All right, excellent. All right, so let's talk about this. So we are going to, one of the first medications that are going to, and sorry, I need to organize this a little bit better, is going to be the metformin. The metformin. The metformin is the glucophage. Is the first line. Increase insulin sensitivity. That is what it's doing. It's going to, the keyholes of the doors are going to start working properly. Okay? So what are going to do this medication? Diarrhea. That is the most common side effect that they like to ask you in the NCLEX, in NCLEX. Okay? All right, so no lactic acidosis. Produce lactic acidosis, can lead into lactic acidosis. And it's very difficult to handle by the kidneys. So no renal insufficiency. Not in renal insufficiency, no renal failure. Okay? All right, so hypoglycemia does not occur in therapeutic dose. So that's why it's the first line. It's very safe, very good. The main problem is diarrhea. This diarrhea is temporary, it's not forever. So you're not going to have diarrhea the rest of your life. It's just for a few hours, not even few days. GI adverse effects like high levels of gastric acid. So it can produce gastritis, can produce dyspepsias, it can produce stomach upset. You know what is stomach upset, right? And that is prevented with food. All right. So just not to here, what is doing this metformin are going to decrease the glucose in blood. How? They are going to decrease the glycolysis. The glycolysis are going to be actually blocked. All right, so now we have another one that is the thiazolidinedione. I call this Celine Dion. Thiazolidinedione, right? So these actually decrease the same way of the metformin, but they produce hepatotoxicity. So zone. So I will suggest not to remember this, but remember zone. Celine Dion, zone. The zone of Celine Dion. So in order to just link this if they're coming in your exam. Sometimes they're coming with this name. Sometimes they're coming with this. Is 50-50%. But just remember that way. Hepatotoxicity. Then we have the glucose absorption at the level of the intestine. That is the acarbose. All right. So acarbose, actually, they need what they like to ask you about that. Acarbose are going to be that you need to take it with the first bite of each meal. Very convenient, right? I'm going to eat now in 5 minutes, 10 minutes. Okay. Passing 5-10 minutes. Okay, I'm going to eat. Okay, my pill. Acarbose. first bite in every meal. The glucagon are going to be the, don't remember aminomimetic agent, just remember the pramlintide. Pramlintide. I'm sorry, that is the memorization portion. So glucagon is going to decrease the glucagon. Pramlintide. So that is the only thing I want you to remember about that. The administration, yes. This can be subcutaneous, intramuscular, or IV. These heads are questions for the exam. Glucagon, what is the way you administer, is all parenteral. Subcutaneous, intramuscular, or IV. Okay, so let's go back. The B1 metformin, we already talked about, and these are the headaches. Okay. What time is it, please?
145.
1:45. All right, so here we have, we already talked about this glucose, decrease the glucose absorption, and glucagon. So glucose, just remember metformin, decrease the by the metformin, diarrheas, right? So then acarbose, the first bite. Simple. Glucagon are going to be the name, and I want, and the name, please, huh? And you need to, the presentation that is coming with. All right, so let's talk about the insulin, increased secretion of insulin. We have the sulfonylurias and incretins. The GLP-1, GIP, DPP, those are receptors for the glucose. So the receptor for the glucose in the beta cells. Okay, beta cells are cells. The beta cells, they have receptors. Those are the GLP, the GIP, DPPI, DPP4. So they're not going to ask you this in NCLEX. I mean, what is GLP, DPPI? They're not. All right, so let's get started. Here we have the sulfonylurias. So insulin secretion. In the insulin secretion, we have the sulfonylurias and the incretin. If you go previous to the slide, oral antidiabetics, insulin secretion, sulfonylurias, and incretins. So these I put it here. Sulfonylurias and incretin. So we have first generation, second generation, and we have different drugs of incretin. So let's get started. So the most common and the most elderly one is going to be the diabines or the chlorpropamide. So that is tolbutamide. First generation, second generation is the glipizide. They're not going to ask you which one is first and second generation. That is the relief. What I want you to remember is two things. Let me see. Two things, yes. One is that they can produce the anti-abuse effect, the diabines. What is the anti-abuse effect? Somebody can tell me? What is anti-abuse effect?
Not sure.
One not sure. So anti-abuse effect is pharmaco 1, drug abuse, alcohol.
Ah.
Yeah. Okay. Anti-abuse is going to produce nausea and vomiting. Right? Remember that? Okay, perfect. So diabines can produce, so you cannot mix with alcohol, this medication. Diabines. The diabines will be a nice name for a bar, right? Let's go to diabines. It's a bar. So that you cannot drink there in that bar. Okay? Hepatotoxicity, and this medication, sulfonylurea. Look at this, sulfonylurea. If you are allergic to sulfas, you cannot take this medication. Okay, I'm not going to go that. The incretin and is the beta. This is always coming for the exam. All right, so sulfonylurias are going to be taken 30 minutes before meals. The beta that are going to be taken 60 minutes before meals. Beta. That's what it's doing, is to activate the receptors of the receptors for the of insulin. The last one I want just to go is the Janubia. Sounds like a girl's name, right? Janubia. All right, so uses alone or in combination, but not with insulin. I want to review this, so please disregard this morphine. I don't know what is doing that morphine there. It's probably a typo. I'm going to delete this. All right, so that's all. So,
Dr. G,
yes.
what's Samoji? You told me to remind.
Okay. So I have 10 minutes, right?
Yes.
Okay. Samoji effect. Samoji phenomenon. Underdown phenomenon. Okay. All right. So basically, it's going to be hyperglycemia. Samoji effect. Samoji effect. We was mentioning that is actually a cause of hypoglycemia. Hypoglycemia. So that is happening at night. So when you are taking the Lantus, that is the long acting, okay? So maybe 10 p.m., 11 p.m., 9 p.m., whatever you want. That is going, you need to take some snacks before, neat snacks before go to bed. Because if this long acting is true that it's going to last 24 hours, in the next few hours, in the morning, in the midnight, are going to produce hypoglycemia. Because they didn't take the snacks. So that is going to produce a very hypoglycemic state. Okay, that is dangerous. Okay, so what you need to do is to always, to prevent Samoji effect, you need to take some snacks just before go to bed and after you inject the Lantus or the long-acting insulin. You okay with that? Hello?
Yes.
Yes.
The Samoji phenomenon, the Samoji phenomenon is a rebound effect of the hypoglycemia. A rebound effect. These rebound effects are going to release, because you was having hypoglycemia, you're going to release what? You're going to release more glucose. So gluconeogenesis, by glucogenolysis, glucagon, all these are going to produce an hyperglycemia in the morning when you wake up in the morning. When you wake up in the morning. This can be temporary because when you are moving and you wake up, you're going to have some activity. So you're going to consume that glucose. But be careful with the Samoji phenomenon, Samoji effect. Down phenomenon effect is going to produce hyperglycemia as well. But this hyperglycemia is because of the release of some hormones like cortisol and growth hormone. Well, not growth hormone. It's going to be more the adrenaline. So this down phenomenon is going to occur between 2 a.m. to 8 a.m. in the morning. Somogy effect, Somogy phenomenon can happen anytime during the night until the morning when you wake up. Okay? 9, 10 p.m., 10, 11. All right, guys. So that's it. Juliet, what do you think about the lecture today? Please.
It was good, but it definitely was like a lot of information. So like my brain feels full.
Good. Good. That means that you have a lot to work on. Excellent.
Yes.
Very good. Keep going. Keep going. Rinsing.
Yeah, it was good, Dr. G, because we see lots of diabetes patient at the clinical side, so it's good to know like in detail. So I learned so much today.
Thank you, Miss Rinsing. Miss Erica, please, your knife. I mean your comment.
Dr. J, my brain hurts.
Excellent. That means you are growing. Very good. Yes. Yes. But anything that you want me to improve or do better, please? Erica.
I feel like sometimes we go on a topic and then we go somewhere else and then we go back. So that kind of like confuses me. I mean, that's for me.
Okay. So what part is that? Yeah, I know. I was talking about something, but I did it like 2-3 times. Why? Because I'm trying to review you for HESI. Normally, I don't use that. For example, we was talking about the anti-abuse. If somebody asking, I don't know what anti-abuse, I will. So, but if somebody don't answer, so I enforce I cannot stop myself. I need to tell you in order to refresh you. So, okay, so I will not do that reviews
No,
again.
Dr. J, no, that's fine. I mean, like we were talking about treatment and then we went to educate. What is that? Well, it's just, but it's okay. It's okay. I mean, if we had to talk about something, then that's connected to the topic, you know?
Okay, Miss Erica.
It was just for me.
Okay, my dear. Mr. Nathaniel, please.
It was good today. I really like the one nose, two eyes, and the ears thing. If you could come up with more of those, that really helps out a lot with the learning.
Yeah, it's a lot of less weight on your shoulders, by the way. But you know what? The first time I was teaching pharmacology, I was pushing the students to learn all the table. And that was really kind of, very, very cruel, I guess. But now with the time, I can trim whatever you're going to see in NCLEX and HESI. And I want everybody to pass HESI. So if you don't pass HESI, you will see face-to-face me. Okay, no, I'm just kidding. I'm just kidding.
Tough love, Dr. G.
Thank you, Nathaniel. Mr. Christian, please.
It was good. A lot of info, but good.
Thank you. Driana, please.
Hi, Dr. G. It was good. I definitely need to go back and review. Thank you.
Okay. The exam, I promise, is going to be the level you want, the level you need, the level you deserve, the level that is going to make you feel proud of yourself. Okay, don't cry, but you're going to cry of happiness. Okay, don't cry of others. So feel proud of yourself. I'm going to challenge you next time. This exam is actually going to be intense. All right, Jarell, please. Thank you, Adriana. Do you accept the challenge, Miss Adriana? Yes, you. Do you accept the challenge or no?
Sure.
Yeah, you are. So you accept the challenge, Rinsing, Juliet? Erica, Nathaniel, Christian?
I do.
Excellent.
Challenge accepted, Dr. G.
Excellent. Excellent. Jerel didn't say anything. Jerel, tell me, what is your comment about the class today?
I actually enjoyed the lecture today because I am diabetic, so I learned a lot more about myself.
Oh dear. Well, thank you for sharing that with us. Yeah, I hope that you enjoyed very much the class. Muchas gracias. Thank you, Gerald. All right, so let's see. Mystery? No, it's not mystery. Miss Anna Constantino, please.
It was good, Dr. G. Thank you.
Okay, Miss Anna. Miss Charlize?
I liked it. Everything is making sense now. I'm making connections in my brain.
Okay, Charlize, Miss Charlize. Excellent, excellent. Miss Alejandra, please.
I liked it, Dr. G. It was just a little fast.
A little fast. Okay.
Yeah.
Even I cut the lecture in two.
Yeah,
Because
it was well for me it was a little fast. Like
no,
I was
no.
writing very like rushed.
But again, please, I don't know if you are doing this, but I suggest not to write down anything without understanding. So, and that's one of the, I'm not saying about Alejandra, but in general, if somebody is writing everything I said, that is not going to take you anywhere because you're actually filtering a lot of information that you didn't copy because your hand is not that fast, and your writing probably making mistakes. And when you want to write down, you don't understand your writing. So why are you doing that? So understanding and take notes of what you understand, that is the way. If we are doing other way, I'm not saying this is the case, but in general, I recommend not to do that. Okay? Excellent. Thank you, Alejandra. So if you have a review or something, just let me know, please. Okay? Mr. Jacob.
The class was cool. Like what Rinzen said, we do have a lot of people who are diagnosed with diabetes, and it's good to hear more about it.
Excellent. Excellent. So yeah, so I hope that is going to be clear. I know there's a lot of material, but I give you the best of my efforts to give you exactly what NCLEX want you to know. Miss Anna, please. Miss Anna Arias, please, your comment. Wrap up.
Okay, I enjoyed the class. I think I just need to touch base on the pathophysiology of diabetes. It was a lot to like take in, but I think it's just with review would be better for me. But overall, I really liked it. Thank you very much.
Thank you, Miss Anna. My last thing is for all of you. I'm paying attention of students who are focused on the class. So students who are standing up, going away, disappear, coming back. So they're going to have pieces, and pieces is not going to make sense when we are talking about the whole picture. And if somebody's coming, and definitely that is mostly happening, that I don't understand is because they're not paying attention. And all this, unfortunately, is not going to occur with me anymore because this is my last lectures with you. This is my last module. So next module, I'm not going to teach any course, probably some simulations. And I will not see you face to face because having me face to face, you don't have any place to escape. Completely sure. All right. So, but you can do that here in online. But anyhow, so in general, please try to focus. Just to finish, when I was in the med school, the doctor was telling us, when you go to class, it's like you are going to church. You're going to church. when you go to class, right? I'm not a priest, of course. I'm not feeling priest, but definitely the quietness, the silence, the focus, the concentration is like when you are going to go to church. All right, so practice that. I will say that is going to help you a lot. All right, muchas gracias. So I will see you next.
Dr. G,
What? What?
I have a question. When are we gonna do our HESI review?
Oh, Saturday and Sunday,
What time?
9 o'clock. Oh, nine. Well, I will try to do 8 o'clock. I was talking with a group at night, and they give me idea to do Saturday and Sunday 8 o'clock p.m. But I need to
Yes.
consult the group too. So if you agree with that, that will be okay.
That's perfect.
Yes, thank you.
So is it tomorrow, Saturday, Sunday?
Oh my
Or
God,
for-
tomorrow? Oh my God, tomorrow. Oh yeah, yeah. Well, I put my word already. Okay, okay, Juliet. Okay, dear.
8 p.m. You said, not a.m. correct? 8 p.m.
8 a.m. Could be a good idea.
No, did you say? I'm asking. Was it p.m. or a.m.?
You want to
8
change?
p.m.
Okay, let's change
8
it.
p.m.
8 p.m.
8 p.m.
I'm not going to play. 8 p.m. p.m.
Perfect. Thank you.
Okay, muchas
Have a
gracias.
good weekend, Dr.
Thank
G.
you. Bye,
Thank
Dr.
you.
Gracias.
Bye bye. Bye bye. I'm going to stay until the end. Somebody need help or something. Miss Anna, can you stay for a little bit, please?
Okay.
Yeah, Miss Rinsing, any question?
Yeah, Dr. G, I text you. I mean, about my EQ.
It's about yeah, that's what I want to talk. Let me stop the recording.